gone, ferry's gone.
I love how
What
this
else could
article,
you
the
do?
nurses basically grabbed the doctors and said, you've got to call the
Hovercraft!
Welcome to CFP Distilled. My name is Dr. Simon Moore.
And I'm Dr. Paul Dillon.
Every month, we look in the CFP Journal and find the most clinically relevant articles for family doctors.
And we explain them to you and get them ready and distilled down for what you need to know for the family medicine exam.
So let's dive in and start, as we always do, with the cover critique. What is going on here?
Oh, starting the new year off, I'm not too impressed. Look, it's a standard stock image of
That's right.
a protein. Is that the sixth step of the Krebs cycle?
It looks like they just Googled complexity and they got a complex image.
And
Really outdid yourselves this time, CFP.
I'm gonna give him a 5. That's
Wow,
average.
generous.
It's only I give him a 3. It's only because it's in color it gets 2.
Okay. So not much substance there.
But lots inside.
That's
Lots
true.
inside this month.
So we're going to do 4 articles today. We're going to talk about,
We're gonna start off with ASA use in pregnant patients.
we're going to
What's
do
next after that?
chronic wrist pain in adults.
Adults. And aortic dissection, really interesting article. I think you've got a close connection. So do I, to where this article happened. Amazing one coming up.
And we can count really well. So that's all 3 articles that we're going to do today. So let's start with the tools for practice. Nice, quick, straightforward one. Aspirin, risk of preeclampsia. What is your go-to there?
So 2% decreased risk of preeclampsia. And that's not the only thing with ASA in pregnancy. Do you remember the exact weeks that you would give it? Maybe
Yeah,
look
so
that
we
up.
want 12 to 28 weeks gestation. Every article we see in the CFP Journal last year, they're a little bit different, but the tools for practice is saying 12 to 28 weeks gestation.
12 to 28 weeks gestation, patients getting a daily dose of ASA, 81 milligrams, 2% decreased risk of preeclampsia, 2% also decreased risk of preterm birth, I believe.
Yeah, so I think the big question though is to ask who should get this, because there are some risks we're going to talk about too. So the people who are going to benefit the most are those who are at high risk of preeclampsia.
High risk. So those with hypertension, maybe there's some renal disease as well, autoimmune disease, diabetes. So
Yep.
broadly speaking, cardiovascular risk factors.
Yeah, so those are the high risk factors. If they've got 2 of the moderate risk factors, then you're going to consider giving them ASA in pregnancy as well.
Sure.
So
Is that what the article says?
Yeah, so
That's what it is.
nulliparity
Yeah.
if they're between
Oh, and
35 to 40 years.
Age. So age, another key thing to ask.
And I mean, whenever you're studying or if you're stuck for a risk factor, just say if they've had it before.
Yeah. You know what? That's actually a great point for the exam. Sometimes you're looking for contraindications to something, and if this person had an allergy to it, well, that's a contraindication. It's those simple things on the exam sometimes can get you an extra point.
Absolutely. So sometimes there can be downsides of giving aspirin to folks in pregnancy.
Especially if they had an allergy to it. But what else could it be? So there's risks, though, of bleeding. I don't know what the exact percentage was for that one.
Yeah, vaginal spotting, the number needed to harm for that is going to be 14 to 20.
Okay. And then you could have a postpartum bleed or postpartum hemorrhage, slightly increased, like 1% increased risk for that.
Okay, and then there's also intracerebral hemorrhage for the newborn, and that's a lower risk, about 0.06%. There's debate about if that's causal or not.
Oh. That's going to be a tricky one. If I'm talking to my patients and counseling them appropriately on risks, and I say, you're going to have to be, I don't know, that's going to be a discussion you're going to have with your patients, but you got to mention those. Because if it happens to your patient, you haven't documented, haven't discussed it, informed consent, big issue.
That's true. And so you may have a situation where your patient comes to you and says, are there any other options, doctor?
You're going to answer yes, there is, because you got to know second line treatments for the exam and in real life. So it's going to be exercise.
You got it. Yeah. So you're going to ask them 140 minutes weekly of moderate intensity exercise. Another great way to reduce your risk of preeclampsia.
Brilliant. So I think that's great. I've seen a lot of articles about this in the CFP Journal. I bet you it'll show up on the exam.
So let's flip to another one. This is a really practical article. I love this one. It's about chronic hand pain in adults.
Wrist pain.
Wrist pain in adults?
Yeah.
In adults, I think that the hand and the wrist are pretty closely
Are they
related.
connected? The
They
hand
are
bone's
related.
connected to the wrist bone.
All right, so I'll give you that one. So wrist pain in adults, chronic wrist pain in adults. What is it that you're going to get on history?
So on history, you've got to ask about handedness. Is it their dominant hand? You've got to ask about occupation. The number of times I've seen where that's been missed, absolutely vital for the exam. You've got to know what are they doing with that hand.
And it always comes back to as well to what happened in the past. Like,
Yeah,
have you had an injury before? Have you had trauma before?
Was there surgery in that joint that was done before?
Yeah. Has there been masses in that hand before? And then ask them about their symptoms.
Symptoms. Or is it daytime? Do they have symptoms in other joints, or is it just that? Thinking more about rheumatoid disease.
And getting right into that wrist as well. Is it clicking? Is it catching? Is it popping? Is there swelling? Is there stiffness? Is there instability? Just a big long list of symptoms we can be asking about.
Brilliant. And then, so what do you do now? You've got this wrist in front of you. There's a couple of really interesting kind of movements or tests that you could do, physical exam findings. But the one thing you want to do is their range of motion. And there's 3 things you want to remember. You want to test their movement against resistance, and then active and passive. So you have to wrap the ROM. Wrap the ROM.
Wow, that's a great 3-word mnemonic. So you've got to try and drill down as well. Where in the wrist is this pain coming from? And this article's got a great flow sheet that shows us which part of the wrist is the pain coming from. And so they've divided up into 3 areas.
So I'm a simple emerge doc. Those are the only things I need to know. So is it in the dorsal aspect? Is it radial, or is it ulnar? So splits it up into 3 areas.
And I mean, it may sound complicated, but we've seen all these things in clinic before. You've seen these in residency training. So when it comes to radial, probably the most common one is that when you do your Finkelsteins and the patient jumps off the bed, there's so much pain. And that diagnosis is de Quervain's tenosynovitis.
Tenosynovitis. Yeah, that's another one. And the other thing we're always wondering there is there scaphoid tenderness, scaphoid non-union? That's the big one on the exam. Happens all the time. I've seen it once or twice actually in clinical practice as well.
Mm-hmm. And then one that you've definitely seen many, many times is the history of osteoarthritis. So specifically your thumb carpal metacarpal joint OA.
Yeah, see that all the time, especially in adults. Remember, we're talking just about adults for this one.
So what are the 2 ulnar causes of wrist pain?
So ulnar, the first one was, now this one I've seen a lot more in the emerge literature. It's come out, triangular fibrocartilage complex injury.
Yeah, the TFCC, I've seen that. And then the extensor carpi ulnaris tendinopathy. There's a really cool exam maneuver you can use to try and diagnose TFCC. So for this one, what does it say? To stabilize the radius and ulna with one hand, and then use the other hand to ulnarly deviate the wrist. So let's angle it that way. And then you're going to put a compressive axial force right down. So are you getting any pain there? Any pain?
Ow! Oh my God!
Does that reproduce your symptoms?
Oh yeah, it does.
Yeah, exactly. So that's a positive TFCC compression test. That's going to suggest that our patient's got a TFCC injury. And how would you describe that?
It's almost, I would say it's like the Sperling test for the wrist.
Yeah, exactly. Yeah, so for when you're looking for cranial radiculopathy, cervical spine radiculopathy, and you take your patient, you get them to extend their head, turn to one side, and push directly on their head, you can demonstrate that. So yeah, you're right.
That's a great one.
Very similar maneuver.
Yeah.
Last category of chronic wrist pain in adults is the dorsal pain.
Dorsal. So this is that classic ganglion cyst patient.
Oh no, that's just your ulnar.
No.
You don't have a ganglion cyst.
Don't have a ganglion cyst. That's one that used to smash back in the day.
They would call them the Bible cyst.
Bible cyst.
You get your Bible, which every good clinic had back in the day.
Yeah.
And you would raise it as high as you could and smash the cyst.
I'd love to see the informed consent before that one.
Why don't we do that anymore, do you think?
Because it would recur. That was the big thing. Yeah, they would recur.
I haven't seen a Bible in a clinic in a long time.
No.
That might be part of it.
It could be.
Yeah, and I think
where the clinic is.
I think smashing your patient is with an object is not specific.
It's hard to explain in court.
Yeah.
I was treating the patient.
One last dorsal wrist pain chronic cause.
Scapholunate ligament instability.
Yeah, so if you've got your the ligament between the scaphoid and lunate, sometimes you get a dissociation there, sometimes you get dislocation. Sometimes you get that widening instability. I love the X-ray sign for that. When you get the widening between the scaphoid and lunate, the Terry Thomas sign.
Because the gap in his teeth.
Yeah, he's an old comedian, I think he was, with a big gap in his teeth, and that's what it looks like on the X-ray as well.
Interesting. We'll have to flash a picture up on the for the YouTube watchers.
So and just like slap in the face for the podcast listeners, I guess. You just have to imagine it. We'll paint a picture with our words. So that is a fantastic article on wrist pain written by some plastic surgeons and an ENT surgeon.
Oh, interesting.
Yeah.
Bored of the nose.
Not sure why they're doing wrist pain. So our third and final article. Let's move on to this amazing story. I honestly, you watched me read this. You saw my jaw drop in the middle of reading this article.
I know this guy, or you'd heard of the story, and it's from my town where I practice, Sechelt, BC.
Yeah. So the patient's name was Dr. Klein, Oh wait, confidentiality. Can we say his name?
I'd say so. He wrote the article.
That's right. I love how.
So wait a second. He's the article author.
Yes.
And the patient.
Yes.
So he did peer review on himself.
And one of the photographers in the article as well. It's such.
He's really did he put that as a separate line item on his CV? Incredible story. If you haven't read this is an article to read start to finish.
Oh gosh, it's a story for the ages. Wait till you hear how they transported this guy. So not only did the guy write the article, take some pictures for his article, but
he survived.
Survived.
See it published.
So this all begins in a small town called
Seashell, BC.
How do you know Seashell?
Because I live and work there.
That's exactly right. So Dr. Klein was raking gravel December 19th, 2022. I remember this was around Christmas time because I know some of his family members socially. And he said, it says in the article, I experienced searing interscapular pain and collapse.
Does he walk around and take notes?
Maybe, yeah. I mean, he couldn't even call 911. He was having such bad pain.
But he was able to start writing an article.
He's like, maybe I can get published on this. It's such a fascinating, it's a mind-bending experience to read.
It's a killer world out there in the publishing world,
Oh, okay.
Mm-hmm.
Okay.
Yeah.
Not bad. All right. So the ambulance shows up 3:58 p.m. They take him to the ER, and they basically say he's got chest pain.
But this is interesting. So this is a takeaway point. This is incredible because it's a family physician who've had it. If you have someone who's coming in with chest pain and it's in their back, I see loads of chest pain, loads of MIs and STEMIs, but if it's into their back, I think I'm going to be getting them into the CT scanner. So they did. They started treatment for potentially an end STEMI, got the ECG. Bit of a delay though to get him into the CT scanner. I think it took about an hour and a half.
That's right.
And look at this, Dr. Ruin Van Rooyen.
Yeah.
I work with him.
They call in the arterial line.
A picture of this article.
Yeah, it's amazing. Oh, and the best part, it hasn't even shown up yet. So,
Yeah.
Dr. Klein, the patient, who's identified as MCK in the article, even though his name is at the top, it talks about how his blood pressure starts to go down, and they realize on the CT that he's got a dissection. He's got a type A dissection.
And what do you do for that?
Get him on a seashell.
Get him on a seashell. Yeah. Get him to a vascular surgeon. Something incredible. But wait a second. I live in Seashell. It's rural medicine. So how, Simon, are you going to get him out of there? There's no ferries left.
Mm-hmm.
It's snowing outside.
Helicopter?
So helicopter? Nope.
Not an option.
So road is gone. Ferry's gone.
I love how
What
this
else did
article,
you
the
do?
nurses basically grabbed the doctors and said, you've got to call the
hovercraft.
Can you believe that? They transported this guy with hovercraft. There's pictures of the hovercraft in the article. There's pictures taken by the patient of himself, getting treated by BC Ambulance Service. It's such an incredible experience.
Yeah.
Long story short, he got his repair. He went into the operating room, alive and
cooled him
well.
down to, what was it, 24
Yes,
degrees?
preoperative hypothermia,
Preoperative.
24.5 degrees. And he lived to write about it.
That's it's an incredible story, but it's a great reminder. It's one of those things in a differential you've got to have up there. And if you're for those that are writing the exam, if you have to list, or if you're in a SU environment, you have to list different diagnoses. You want to list those deadly ones in there as well.
Yeah. So there was a really interesting additional history feature that showed up on this, and that was the numbness. So he had
Interesting.
Numbness in one arm. So that's going to be making you think that maybe it's something different than just a heart attack. And then that searing, tearing pain. And you got to listen. Maybe there's a new murmur.
Sure.
Or some other features here.
Focal neurological. So pulse and BP differences between arms. That I see. The nurses are on the ball for that one. They'll check that if they're worried at triage. But if it's not done, ask for it.
I got to hand it to Dr. Klein. I mean, this has got to be probably my favorite article that we've ever reviewed in the CFP Journal.
Is it?
I've never been this excited.
What about for this year?
We'll see
We'll see if it gets better over the course of the year.
Seeing as how it's January. Well, that brings us to where we are right now. We are in Calgary right now. We are about to do the review course in family medicine for dozens of family medicine residents, practice eligible candidates, right here in downtown Calgary.
Doctors who will not forget about thinking about aortic dissection.
Yeah, so we would love to see you at one of the review courses coming up. So if you go to thereviewcourse.com/register, you can find out how we go through all the 1 of 5 topics.
In one weekend.
It's amazing. So why don't you check that out? We would love to see you. Thanks to those of you listening on the podcast. Thanks to those of you tuning in on YouTube. And this has been another edition of
CFP Distilled.
See you next month. This article is phenomenal. And if you don't know this stuff for your practice, you're in trouble. You're in trouble. Welcome to Family Med Distilled, or as we like to call it,
Family Med Dad.
Family
Jokes
Med Dad.
from the database.
That's right.
Every month,
Dad-
live, uncut.
Dad Joke Medicine. So my name is Dr. Simon Moore. I'm a family doctor in Vancouver, British Columbia.
My name is Dr. Paul Dillon, family doctor as well in beautiful British Columbia.
Yes, and every month we go into the latest primary care updates for your clinical practice, what you need to know. And today we're going to be looking at the February 2024 Canadian Family Practice Journal.
And we always start by looking at the different journal covers. So what do we have on this one? We have a pill bottle. We got some sort of a tap. What are your thoughts on that one, Simon?
Yeah, so this is supposed to represent the drug shortage because the pill, I guess, is not very long.
Oh, the long and the short of it. Actually, if you read the inside page for this one, they talk about how you can use drug shortages to deprescribe. So this is probably from the deprescribing lobby.
Exactly.
Yeah. There's no medication available. Oh, so what should I use instead of insulin?
No idea.
I don't know.
Deprescribe it.
Deprescribe it. Just stop it. You'll be fine.
Okay.
You'll be fine. You don't need the meds anyway.
Fair enough. So in today's episode, we're going to talk about three very important primary care topics. Number one,
we're going to talk about a tale of two bladders.
Exactly. And then number two, we're going to talk specifically about HIV prevention and how you can prescribe a pill to your patient to prevent it. And I'm not talking about PrEP.
Yeah, PIP. I'm going to PIP to the last one, and it's approach to burn treatment in a rural ER. So we'll talk about some of the updates from the article, and maybe you've got a great new resource you're going to talk about as well. So let's dive right in, Simon. Tell me a tale of two bladders.
That's right. We're going to start with article number one, which is about number one.
Ugh. If it was an article about number two, that's a dirty article.
Dirty article. This article is phenomenal. And if you don't know this stuff for your practice, you're in trouble. You're in trouble.
You're in trouble.
So what are these two different bladders that are covered in the article?
So it's going to talk about just an uncomplicated UTI. So women aged 18 to non-pregnant up to 50 or 60, and then asymptomatic bacteriuria. So let's talk about
it. It
the
actually
first one.
says 50 to 60 years of age. It's got that approximate range.
Because then it magically stops after that.
I hope so, yeah.
Does it?
Then it becomes a complicated UTI.
Oh.
Yeah. Because the problems become much more complicated at that age.
Is that just a rant? 60?
That's
They're
what the
going to
article
have to
says.
update that.
All right. So let's take a look at what is that first topic. The patient who comes to your clinic and says, I have a UTI. What are the chances that they actually do have a UTI if they're in that age range?
It's 50 to 80%. 50 to 80%. Just with that one question. That's simplified medicine, isn't it?
Yeah, that's a really high pretest probability. I mean, even if you've got all 4 points on your Centaur score, your chance of having strep throat is only 50%. So if we can get even higher than that with just one history feature, which is they came here worried about a UTI, then you know that you've got.
What about the dipstick? I use the dipstick all the time, everywhere.
The thing
Sometimes
is,
in the ER, it's already done. Does that help?
Not always, because if your patient's pretest probability is that high, up to 80%, and then the dipstick is suggesting they don't have a UTI, well, chances are they still do. It's not a really great rule-out tool. Nitrate's not a really good rule-out tool.
And then you talked to me, we talked about this earlier, where you can sometimes get the culture back. There was a study, I think, 220 symptomatic women, 80% had a positive culture result, but 96% were positive by PCR. So, you know what, the best thing to do is to just actually listen to your patients.
Yeah, exactly. So even a negative urine culture might not be a great test. So stay positive even if they're negative.
Stay positive. Wow.
Now, I think that, I guess that joke wasn't great.
It was kind of an 8 out of 10.
So you think that you're an 8?
Urinate.
Urinate, okay. So the second bladder, I mean, there's two kidneys. There's got to be two topics on a bladder article. The second article within this article, the second bladder, it's a tale of two bladders. What is that situation?
So that's elderly patients, potentially maybe with a bit of confusion, in a nursing care home.
Yeah, and yet they still call it asymptomatic bacteriuria. And that's what really shocked me about this article. Because, I mean, I was trained, if your elderly patient is confused, get that bladder dipped, get the urine dipped, get that culture. And this is saying, no, there's no evidence to back that up.
Yeah, I think what they found is that even after treating these patients, the confusion didn't change. So it's really appropriate prescribing of antibiotics, and we were maybe doing a disservice to some of our patients, just putting them on antibiotics and not digging a bit deeper to figure out what was actually going on.
Yeah, so I love getting rid of the ambiguity in my clinic by using a tool, and so they talk specifically about the LOBE criteria and combining that with the CAM, the Confusion Assessment Method. Take a picture of that one, the CAM tool, with your camera.
That is brutal, which means it's amazing.
Okay.
Confusion assessment method. Delirium is suggested based on acute onset, fluctuating course, inattention, disorganized thinking, and altered level of consciousness.
Yeah, so if you've got those criteria, then we want to look at those LOBE criteria, and only if they meet those criteria should we get a urine culture. So what are those criteria?
So I have not the best frontal lobe, so I have to read these ones out. So minimum criteria for ordering urine culture. So they got to have a fever over 37.9. 0.9. Eh? They couldn't have just said 38.
No.
No. Or a 1.5 centimeter increase from baseline. Plus, they've got to have some dysuria, urinary catheter, some flank pain, shaking, chills, urinary incontinence, gross hematuria, which is, it's just gross, isn't it?
It's disgusting.
Disgusting.
Yeah. So this is not those folks who they were fine and we dipped their urine, or they were a little bit confused and we dipped their urine. These are overt, obvious folks who have bladder infections.
Yeah, they've got symptoms. They would have, if they were under 60, they would have told you about them.
Yeah, because the evidence is quite clear that there's inappropriate prescriptions written 35 to 93% of the time. So,
wow.
I think that your inappropriate prescriptions are closer to 100% of the time?
Yeah, 100%. All my prescriptions.
Yeah, that's because you write swear words and draw nudity. That's an inappropriate prescription. You need to not have that stuff on your prescription. No, obviously they are referring to folks who got an antibiotic when they shouldn't have. Well, let's keep things flowing after that urinary tract infection article. And I think there's a lot of P in the future when we look at this next article.
Yeah, so let's go P to P. So this is, I'm going to see how fast I can say this. Post-exposure prophylaxis in pocket for HIV prevention. That's not bad.
You know what's wild is prophylaxis in pocket. The abbreviation for that is PIP.
Yeah.
Who, as you know, was one of Charles Dickens' characters. Just like A Tale of Two Bladders is like that Charles Dickens story.
Do you think they actually sat down
and
had an underlying theme? They
Yes.
asked AI probably to come up with titles for all the...
Of course.
This is a Dickensian epic.
Exactly. This
Did
whole
he write epics?
journal
I don't know.
is all about the Charles Dickens references.
So we've got some, let's talk, before we talk about PIP, you mentioned PIP, there is PrEP, so pre-exposure prophylaxis and post-exposure prophylaxis. That was PIP's cousin, PEP.
Yeah, so PrEP says these certain folks are at very high risk of getting HIV, so just take a pill every day to prevent HIV, and that's PrEP. That's not what we're talking about here. We're talking about post-exposure prophylaxis. So what's the old-fashioned way to do post-exposure prophylaxis?
So you'd have to come in. So you'd have your exposure. You'd have to come in and start taking the medication. So really the goal of this is to avoid any delays in getting on the medication.
Yeah,
so you've got the medication already.
Yeah, they don't have to go to the emergency department. It's saying, why don't we just prescribe it in advance for folks who are higher risk? Not so high risk that they qualify to take a pill every single day, but keep them on your shelf, have them in your house, keep these pills in pocket. So who are these high-risk people who should be getting PIP?
So the numbers that they actually give is 0 to 4. So 4 exposures a year. Well, maybe that's not enough to be taking a tablet every day, because some of these medications you have to monitor for side effects, which could be, diarrhea. They could have some nausea, vomiting, and there's some long-term effects as well.
Yeah, so more than that, consider PrEP, pill every day. But these folks are lower risk, and so we're going to do PEP in pocket.
So the other thing you have to consider is, before you hand this prescription over, what are the baseline tests you're going to do? So you're going to be doing your STI screening for these patients. You're also going to check a complete blood count, check their liver enzymes as well. And in certain ones, you're also going to do vaccination for monkeypox, Mpox.
Wow, that's bananas.
I quit.
You can quit? Yeah, because my dad jokes are too good for you.
I need some PDP.
Yeah.
Pre-dad joke prophylaxis for doing this.
You need to be immunized against dad jokes.
Could you be immunized against dad jokes?
Get the shot for it. The immunization, the vaccine.
Dad scene.
Mm. There's nothing there. We're both just scraping the bottom of the barrel. Okay.
Bottom of the...
so you have to get a full...
But you know what? That's where the best dad jokes are.
That's true.
The bottom of the barrel.
Okay.
Yeah.
You have to get a full panel of tests. And once you've gotten those, you know that the liver, the kidneys are happy. then you can go ahead and prescribe these.
28. I think it's a 28-day course is what they're saying.
And then
we
we
got to start it within 7 days.
Yeah, within 72 hours.
72 hours.
Yeah,
Sorry,
within
72 hours. Yep.
Of your encounter, and then 7 days is when they need a follow up at that clinic. And that is PEP for PIP instead of PrEP.
Summarize. Beautiful. Okay, so let's keep on moving right along. So our last article from this month's CFP. So we've talked about UTIs. We've talked about just getting into the flow with treating those. And now approach to burn treatment in the rural emergency department. A little bit of a longer one. Some
Another
great resources.
Dickens reference right there.
How is there a Dickens reference?
Isn't one of his characters spontaneously combust?
What?
At the end of Bleak
I went
House?
to a different medical school. I didn't read a lot of Dickens in my med
Sorry,
school.
I didn't. I ruined the story, ruined the ending. A spoiler for one of those Dickens stories. I guess if they were written in 1800s,
What happened in the end of the story?
they spontaneously combusted. It's high drama for back then. They didn't have Netflix or TikTok or whatever the kids are watching.
Wow.
They had to have drama. Boom!
Spontaneously combusted.
The person was gone.
It's like a real thing, isn't it?
Oh yeah, totally. So if your patient has a burn from chemical exposure, inhalation, or they spontaneously combust, and then they come into your emergency department, what are the guidelines? What should we do for these folks?
I would be ashen if someone came in after spontaneously combusting.
Yeah, this burn article is definitely a hot topic. It's lit, I would say.
Ooh.
I'm delighted to review it with you.
Man.
So
Let's go.
this
You're
one
on fire right now.
Absolutely.
I
So
just wanna say.
I love how this article starts before they even arrive in the emergency department. What should be happening then? What should we be training our pre-hospital staff? What should we be writing on an exam if it says what should we do before they come to hospital?
So specifically for pre-hospital care, what they're saying is lactated ringers, 125 ml an hour.
So sorry.
Start that. No
Per kilogram?
calculations, nothing.
No
Nope.
calculation.
Just start them. 125 ml an hour. Now, I think I'll be realistic. In certain places, maybe they don't have lactated ringers. I think it's just really saying start the fluid resuscitation early, and then you can do your calculations and dial it back down to that 2 mils per kg.
Yeah. So that really want to sound the alarm with the ringers, lactate,
Ooh,
ringing the alarm. Okay.
That's good. Good.
Thank you.
Great. That's
Thank
a
you
great
very much.
memory trick.
And then you want to give them, warmth, not too warm,
Not too
otherwise
much. Yeah.
you're getting right back where you started. You want to provide pain control, really important. I worked with a preceptor in Nanaimo who his philosophy was pain should stop at the door of the emergency department, which is a bit of an unrealistic goal, but it's something that we should work towards. I really like that kind of thing.
Interesting. Pain should stop at the door. Close the door. Close the pain door.
Close
Going back to the pain receptor theory. What is it?
The gate theory.
Closed gate theory.
Close the pain gate. There you go.
Close the pain gate. Nice.
So then they are in your emergency department, and there's important stuff to do like tetanus vaccination and counseling about prevention, but that's all way down the line. What are the first steps you do as an emergency doc when these folks come in?
So it's still going to be considering airway, breathing, circulation. Big thing is going to be airway, depending on where the burn is. And then, completing your primary survey. And what about...
I don't want you to be deaf to the next 3 steps. D, E, and F.
Oh, thrown. Bottom of the barrel.
So
winning.
D is for disability, E is for exposure, and then F is fight or flight. No, we don't fight our patients. Flight or transport. So we
Flight or
do fly
transport.
them out.
Yeah. So early consideration in a rural environment. Like get that gestalt at the door where you're treating their pain. If you're giving them ketamine already, you're going to be thinking, maybe do I need to get this patient out? And there's another great point here as well. Any loose, you want to keep clothing loose or off. Anything constrictive, you're going to want to get that off. So
Get rings off.
Anything on the rings, rings on the fingers, any jewelry, all that stuff needs to come off.
Now, when you make that decision, do you send someone to a burn center? I find it amazing how many of my residents don't actually know this. There's specific criteria for who we manage with burns and who we should be sending to a burn center.
So it sounds like a hot topic. Is there a one-pager? You mentioned a resource you started.
Yeah, and so I do like this article a lot about it, but the one thing that disappointed me is they're referring to the old version of the document, the ABA, American Burn Association referral criteria, and it was updated in 2022. They came out with a new version, and the new version is much better because instead of just saying send these folks to a burn center, it says these are the folks that need to go now, and then these are the folks that you need to pick up the phone and talk to a plastic surgeon about them.
Discuss. Okay, talk their ear off.
Yeah, exactly.
Burn their ear off.
Okay. So now that we've figured out the plastic surgeon consult.
So the plastic surgeon is going to tell you to either get undressed or dress the burns.
Yeah.
So do you roof blisters or what? What's your take on that?
Depends on the surgeon, to be honest. Yeah. So I've seen, this is one of the widest disparities of practice I've seen. Some surgeons are like, it's a sterile space, like just leave it, let it heal. There's all these great properties of the sterile fluid, and other ones, get rid of them, de-roof them, and they will crap on you if you don't. I've seen these consult letters where they go to town on an ER doctor and say, these blisters were not appropriately debrided in the emergency department, and so now we're forced to do it in our clinic without sedation. I was shocked.
I don't know. I just find with like the cost of housing and stuff in Vancouver, de-roofing, it's just...
That's all you can afford in Vancouver.
It's all you can afford, yeah.
Is a house with just like...
hard enough to have a roof over your head, and now you want me to de-roof things.
Exactly.
Unbelievable.
So, then we got to dress the burn. How do you dress your burns?
I wait for sales.
Mm-hmm.
Yeah.
Okay.
Like the 40-50% off Black Friday sales, and that's when I look for nice clothes for my burns.
I think the nicest clothes for burns is probably a blazer.
Oh.
All right. So in all seriousness, yes, we want to dress those wounds. Saline and gauze. If you're not in a burn center,
you don't want to end up in a sticky situation.
No, there you go. And then later on, tetanus prophylaxis, and then we send them out. And then they specifically talk about, do they have the admission criteria? Which folks do need to be admitted to non-burn center?
So what do they say?
You got pain management. There's too much pain.
Yep.
There's a superimposed infection, a suspicion of abuse.
Yeah, that's something you gotta think about with burns.
Yeah, especially if you see there's specific patterns. So circumferential burns. You see those with immersion injuries. If a limb has been placed or the whole child has been placed into a bin of hot water, you can get that circumferential burn with a very clear demarcation point.
Interesting. Mm-hmm. Sad, but interesting.
Awful, but really important to know if you want to help prevent future injury.
Yeah.
And of course, folks who have circumferential burns are at high risk of eschars, and those can lead to, you can end up with joint contractures. You can end up with difficulty breathing if the eschars are around your trunk. Yeah. So some of those need debridement for those.
It'd be like the ribs.
Mm-hmm.
Just thinking of baby back ribs.
Oh gosh. Okay. So moving on to our summary of today, what did we talk about?
So we had 3 great articles. Mm-hmm. So one was A Tale of Two Bladders.
Yep. So
we're looking at UTIs. The most important thing, you're going to listen to your patients. 50 to 80% are going to tell you they have a UTI. You're going to treat them.
Yeah. And the second article is the prophylaxis for HIV. And those folks who don't have enough sex, that's high risk that they would meet criteria for.
Like dads.
Like dads, yeah. They don't meet criteria for PrEP, but they do meet criteria for PIP, pill in pocket, post-exposure prophylaxis.
And then we finished off with the hottest topic of it all, burns, with some really unique points there to remember in your ER in rural Canada.
Well, we hope you've enjoyed Family Med Distilled, and of course, it's all about dad joke medicine. See you next time.
Like everything in medicine.
In medicine, do we do this? Do we do that? What do I do for my incontinence? Depends. Welcome to Family Med Distilled, another amazing edition. That's right, we're going to talk about dad joke medicine, and we've got amazing topics for you here today as well.
Today, yeah, we're doing a couple of articles from this month's CFP Journal, March 2024. It's actually a little bit light because I've torn out all of the advertising. Desperate for family medicine physicians across the country. But what are we going to talk about, Simon?
Well, we're first going to talk about infections in kids. That kid comes in with a fever and they got a runny nose and a cough, and it's a really valid question. Should we dip their urine? Do they have a UTI?
And then after that, we're going to talk about 2 different articles. We're going to talk about a topic that will put you to sleep. Insomnia.
Insomnia, exactly. And then there's a second article about insomnia, specifically about the new insomnia medication. My name is Dr. Simon Moore. I'm a family doctor in Vancouver, British Columbia.
And my name is Dr. Paul Dillon. I'm a family doctor in Sechelt, BC.
And we are going to try and cram in as many dad jokes as we possibly can. So definitely, if you come up with some of your own, put them in the comments, because that's what we live for.
Yeah, that's how we build up the database of jokes.
Between the database, between the 3 of us, we got 5 kids, not like together. We both have our own wives. And so what level is your dad joke ability going to be?
I'm a level 2 dad. I've had the 2 kids.
I got 3 kids, so that makes me level 3 dad joker. But
That means your jokes are actually worse. Is that right? It's like
Yeah,
it's a
exactly.
convoluted inverse relationship between the quality of dad jokes and the groans that you get afterwards.
If you don't like them, don't worry. They're only going to get worse. So let's start with this first really valid article that talks about, do we get urine testing in kids who have a fever? What's your answer?
So it depends. God, I hate that, eh? Like
Just like
real
everything-
everything in medicine.
In medicine, do we do this? Do we do that? What do I do for my incontinence? Depends.
Should I have another kid?
No. Please
I
don't.
thought you were gonna say it depends.
No. I met
I'm
your
a
kids.
good dad.
I met you.
Yeah.
Sorry. Trying to throw shade at you, not at your actual children. That's over the line. Sorry about that one.
So here we are. So what does it depend on? Depends on age. So what this article, the article is entitled, it's not even a title, it's a sentence. Should you test for urinary tract infection in children with respiratory symptoms?
Runny nose, cough, maybe some shortness of breath. Should we check their pee? Obviously, the parents will be like, what are you doing? We're looking for the cause of their fever. So if they're under 2 months of age, the answer is crystal clear.
Should be done. Yes, younger than 2 months of age, regardless of whether they have respiratory symptoms. Under 2, you're gonna do.
You're gonna look at number 2.
Under 2, you're gonna
Number
do.
1. No, number 1 is pee.
Number 1 is
Number 2, sorry, I always
Do you always
trying to
mix them
remember
up?
this. Yeah.
Front to back, back to front.
Number 3.
Number
Mix
3.
them up. Is that what happens?
Number 3 is what happens when you get really old. Fecal and urinary
Gosh,
incontinence.
okay. Well,
That's
this
a
is about
special-
children, so let's
Yeah.
stay on topic because I don't like where this is going. So, how about those kids who are older than 2 months of age?
So they use 2 to 24 months of age, and you should not exclude the diagnosis of UTI based on respiratory symptoms alone.
And it's really interesting when you look at the research. Some of the studies said that a kid with influenza in that age group had 0.5% chance of UTI, and other studies said that it was up to 7.5% chance. So you could be missing UTIs if you say, oh, they got runny nose, they got cough. It's just respiratory infection.
Interesting. And so what could you use? I know there's certain calculators. So, I mean, it took me a while to realize that this is an online calculator. You don't just have them pee on a calculator.
Oh, gosh. Yeah.
UTI
Calculator.
Calc. I mean, that's what it says. UTI Calc.
UTI Calc reminds me of that amazing kidney stone calculator for urinary calculi. The Calc.
Boo. The Calc.
So that one's not real, but
No.
UTI Calc is absolutely real and really valuable too. I love it because you type in the variables, the age, the status, what the urine shows, and it tells you the % chance of UTI.
You still have to use the little clinical acumen there, but yeah. So there we have it. So under 2, you do test, and then 2 to 24, use something like UTI Calc. Don't pee on a calculator.
Yeah. And I always warn patients, when I'm pulling out my phone and I start scrolling and typing in their variables, like sometimes they're looking at me, they're like, what are you doing on your phone? I'm like, I'm using an actual calculator to try and determine your symptoms.
Amazing.
Because otherwise they think I'm just Googling their symptoms.
Okay, so that's it for UTI. So let's turn day into night. Wait, what's on this page? Oh, that's a conveniently placed insomnia treatment article or advert right
For an article,
there.
yeah.
Oh, when day turns to night.
So-
Consider, don't say it.
I love how it's an article for an insomnia drug, and the very next page says, don't use insomnia drugs, first line.
That's convenient. Does it actually?
Yeah, exactly.
Oh my God, there's the summary. Don't use drugs.
This article is treatment of chronic insomnia in adults, basically grumpy patients. Like, if you are not sleeping, these are going to be really
But
upset.
I mean, it does have social implications. And so this is specifically insomnia versus in the summer you're sleeping outside. Outsomnia. It's a little bit easier sometimes to take a nap in a hammock. That's the treatment for outsomnia.
Okay. My personal cause of insomnia is having 3 kids.
Oh, yeah. Yeah. Chronic parenthood.
I don't think I've slept a full night in a decade.
Wow.
There's constantly somebody up at night for one reason or another.
Oh, yeah.
So I definitely can't take sleeping pills because I got to be awake for their nighttime wake ups.
So kind of the pre-treatment for chronic insomnia is a vasectomy?
Sounds good. So it's not in the article, but
It's not in the article, but I mean...
Now,
yeah.
they talk about the first line treatment is going to be non-pharmacologic options, and they list several.
Yeah, so this is interesting because this is a challenge. Patients will come in and they almost know I'm going to get a pill or I want a pill. But first line treatment is non-pharmacological. And it's sometimes a bit of a challenge in a quick visit to say, like, here's what you're actually going to do. So there's biofeedback. What else do they have there? They have
stimulus control therapy. You got to control those stimuli.
Oh.
They got multi-component therapy. They got relaxation therapy, biofeedback. But you're right, some folks actually just want a prescription. And so that's why Choosing Wisely Quebec has actually created a tool in English and French, which is a non-pharmacologic prescription pad. It's a non-prescription prescription pad.
Oh, just a pad of paper?
Just a pad.
Just a pad. Why is it Choosing Wisely Quebec?
There's all sorts of different Choosing Wisely's, and I guess in some provinces they choose differently.
Choosing Wisely Quebec, I'd be like, I'll take the poutine. Sounds like the Quebec.
All right.
Quebec.
It's a wise choice.
Wise
But
choice.
the most effective non-pharmacologic treatment, the first-line treatment for insomnia, chronic insomnia, we haven't even mentioned yet. What is that?
CBTI.
Yeah, not just CBT. We're talking about CBT specific for insomnia. How do we access that?
So there's online apps for it. There's websites. There's probably some printed handbooks as well.
And the good old-fashioned, like, hire someone, pay them a crap ton of money, and they therapize you with CBT.
I feel like I do CBTI for my kids. It's like reading a storybook to them.
Oh, okay.
Maybe if you had someone read you a story,
Maybe.
would that work?
Why don't we try it sometime?
Maybe try it.
Give me a call.
You should write a children's book and then read it.
I have written a children's book.
What?
Yes. What a coincidence. I'm glad you brought that up. Thank you.
But hit purchase on Amazon on the link down below.
Yeah.
I feel like we should say
It's currently actually a #1 top seller in a category of children's books about physician parents with hidden clues about developmental milestones and safety risks. Not a big category. I don't know of any other books in there.
Yeah, that's good then. You actually have the top 2 sellers, I think, in that.
Yeah, because one book is called Daddy's Becoming a Family Doctor, and the other one is called Mommy's Becoming a Family Doctor.
It's brilliant.
I appreciate that. That's probably the only time you've ever said anything nice to me. The nicest thing you've ever said to me. Sorry, that's.
I hope nobody's recording this.
So we know that patients want the pills, and so there's a few really key messages about the pills. We've got the insomnia medications, the benzodiazepines. How common are those?
Super common.
1 in 10 65 plus folks are on a benzodiazepine. That's probably way less than it used to be.
Yeah, I think we have seen some movement getting people off these medications. I think key message really is you're not supposed to be on them. When you look at the indications and timelines, like max 14 days for a lot of these. But I've seen them. Patients have been on them forever. It's hard to get them off.
I found that we can talk to the folks about the side effects and the cognition effects and the somnolence, which is shockingly a side effect of
I think
insomnia
what they're referring to is like the somnolence next day.
Yeah,
so
and
the
then
kind
you
of
get
hangover effect.
It can lead to falls, but the one that really convinces people to reconsider their benzos is when I say, this drug increases all-cause mortality.
Oh, wow. Yeah.
You're more likely to die on this medication. It says alcohol or sedatives are involved in 92% of opioid-related deaths. So
why are you co-prescribing opioids?
Sometimes you don't co-prescribe it; they're just getting them somewhere.
So yeah, so increase the risk of falls without increasing the risk of falling asleep.
The wrong kind of fall.
The wrong kind of falls.
They talk about some of these new drugs, the orexin antagonists. I found it really unusual that an article that just came out talks about lemborexin, also known as Dayvigo. That's on the market in Canada. They talk about suvorexin, which is approved in Canada but is not being marketed in Canada. And they don't talk about daridorexin, which is also known as Quvec, which is on the market in Canada. So a couple of unusual omissions from this article, I find.
Someone fell asleep at the wheel.
There we go. So before you fall asleep, let's move on to our next article. Before that, a couple great tools, though, we've got to mention. The Sleep Well website puts you to sleep, just like reading Paul's autobiography. And also, deprescribing.org has a great flowchart to help you navigate those conversations with when should you be on an insomnia medication, when should you not, how do we get you off this medication.
Interesting. Okay, so 2 great resources there. Brilliant. So let's move on to the next one, which is those orexin antagonists, the ones that you just talked about, for insomnia. Do they actually work?
They do. Well, depends what you mean by work. Like if we're going to give somebody suvorexin, which is not available in Canada, lemborexin, which sounds like a car I couldn't afford.
It's expensive though. On that point, like
Lamborghini-exin.
It is expensive. $50 a month for 30 tablets. You know what that's going to do? It's going to keep you up at night worrying about your finances.
Yeah, but you can't put a price on sleep, right? So
I think they did.
Yeah, they
it's
did.
$50. It's $50 a month. That's the price.
Wow.
Yeah, you got to be willing to pay.
But there's a great rule of threes you came up with. So rule of tens.
Rule of tens.
To help us decide, is this the right medication for a patient? So CBTI has failed. The other non-pharmacologic options have failed. So what do you tell your patient about these new drugs?
So for the new drugs, the evidence isn't great. So you'll get to bed 10 minutes earlier. You'll stay asleep for a total of 20 minutes. So you could say 10 minutes at the beginning, 10 minutes at the end. But then 10% are going to have daytime somnolence the next day.
So, I mean, if you're down on the list of things you've tried and there's nothing better, then your patients are definitely going to want to try this if they can afford it. Does it work in older folks?
So similar efficacy in those over 65.
Yeah, they've specifically studied that. So I find that really, really useful.
And we don't know about abuse yet for these new medications.
How convenient. They didn't actually study the abuse potential of this when they were trying to get approval for it. They didn't ask the patients, are you addicted to this medication? Now, there are really key features here as well about, figure out why else could this patient have trouble sleeping.
Sure, it comes back to the basics. Maybe you've got this kind of flow and you've just going with it and you haven't really gone back to ask those key questions. What's underlying this insomnia? Why can't you sleep?
Mm-hmm. Well, if you've got nothing else left to add, then I'd say let's put this one to bed.
Let's put it to bed. Beautiful. I'm Dr. Paul Dillon.
I'm Dr. Simon Moore, and we will see you next month for Family Med Distilled. That's right, dad joke medicine.
And now they're catching up.
Yeah.
The days without fever are more rare.
Exactly.
I take them to the emergency room if my kids don't have a fever.
Welcome to Family Med Distilled for April 2024, also known as
Family Medicine Distilled, or Dad Joke Medicine.
You got it. In this video, we are going to talk about top articles relevant to primary care in 2024, as well as
we're going to just flow through this other article on urinary incontinence.
And then
is the article on cough?
Apparently, yeah. And then we're going to wrap up with a groundbreaking article. Massive study. Is Tylenol, acetaminophen, paracetamol safe in pregnancy? But first, let's go through top articles.
Top articles. So we're going to start with one about lipids. So this one frustrated me because all of a sudden I'm in that guideline.
Yeah, all of a sudden the articles are relevant to
They're
you.
relevant to me. I much preferred it when they were about, screening for STIs under the age of 30, for gonorrhea and chlamydia in Canada, for everyone. But no, now it's about lipids.
Yeah, and as we get older, the other day I looked at a medical textbook and the table of contents looked like my past medical history. So, statins and high-dose lipids. Treat to target. Do we treat to target? Do we aggressively get that down? Because that's what the guidelines recommend.
So this concentrated on treating to target, or this start low, go up. And also specific to South Korea study. So I don't actually know any South Korean docs. That maybe it's a different practice style, why they did this study. Do you know what the North Korean study said on this?
No.
No, it's silence.
Oh, okay. We
No.
haven't heard from them
No
yet, I guess.
studies coming out of North Korea yet.
All right. Now, they took 4,400 patients in this study, and they compared the one group, they reduced their lipids. They tried to treat to an LDL target of below 1.3 to 1.8. And the other group, they just
gave high dose.
gave them a pill.
Boom.
Torvastatin, 40 milligrams, or rosuvastatin, 20 milligrams.
Yeah, I think if patients are tolerating the high dose, I think there's a validity to this. We know we're not testing as often.
Does it work, though?
Does it work? Well,
And it's exactly what it said. 3 years later,
yeah.
no difference.
Oh, interesting.
No difference in cardiovascular deaths, no difference in all-cause deaths. So I think you're absolutely right.
Yeah, you just think about all the repeat visits. You're kind of setting it and forgetting it.
Yeah.
That's what you're going to do. Now, ezetimibe, I think they used in a small group.
Well, they found that the folks who, when they're treating to target, they ended up giving them more ezetimibe.
Interesting.
Because they weren't getting to target. But we know ezetimibe, not that great evidence. It's not first line, not as
Side
helpful.
effects as well. Yeah, so, for me, if I can get my patients, instead of treating to target, I'm going to give you this and say, we're done.
Yeah, so
check your cholesterol one more time, and that's it.
focus on ezetimibe. We're going to give
Ezetimibe.
high-dose statins because it doesn't actually make much of a difference when it comes
Yeah.
to treating
And
to
myalgia
target.
was the other interesting thing, wasn't it?
Yeah,
so not in
exactly.
this study, but do you remember?
Yeah, we just saw in a different study about myalgia. It turns out after 1 year, the rate of myalgia is identical in if you give somebody a statin or if you give them placebo.
Yeah, so there's like a baseline pain of being old and on a statin. That's what it is.
Yeah.
14% of people. It's going to be you and me. Put it this way. Did you wake up this morning? Were you sore?
No comment. Everywhere.
Everywhere, yeah.
Well, thanks for giving us the stats on statins.
Statin stats. There we are. So let's move on to...
We are going to go to Wegovy. That's the brand name for this next medication, semaglutide.
Semaglutide. Okay. And tell me
celiacs
about
hate
it.
this drug
Why?
because of the glutide.
Oh, those like super sensitive to gluten.
Yes, they're
like
so
even
sensitive.
the word.
They're sensitive to things that are very sound like gluten. So what is this study's question? Can semaglutide reduce cardiovascular events in people who are obese and, hold on, don't have diabetes?
Don't have diabetes, but do have known cardiovascular disease. That was the key population here.
So let's find out what the study said. So 17,000 adults.
Yeah, it's big enough.
And what did they find?
Yeah, so after 40 months, so 1, 2, 3, it's a weird 40 months. Like, why did they go 3 years and a bit? I'm sure there was a bit of fluffing to get to the right months to get something valid.
Not
out of
an
these
industry-funded trial, really?
Yeah, no, they never do that.
Okay.
No, it's like a parent-funded study. Earlier sleep is better.
Yeah.
Cardiovascular events, death from all cardiovascular causes, non-fatal MI or stroke, occurred in 6.5% of the people on semaglutide, and then 8% with placebo.
That's right.
No difference in mortality.
Mortality was the same, but the semaglutide group was probably a bit happier because 9% of them lost weight versus only 1% in the placebo group.
Okay, so happier being less heavy.
Yeah,
But
and
once again, no mortality. And then you got to think about the cost.
cost is
as
a big
well.
one.
Lightens your pocket.
Availability is a big one. Yeah, you lose weight, you lose money. And then availability is hard to find. And finally, a lot of GI side effects.
I think we see that across this class,
Yep.
don't we?
Yeah, we see that with all of those ones. Speaking of class, let's get brushed up on RSV.
Oh, what does RSV stand for?
Respiratory syncytial virus.
Oh,
No relation
I would
to
say syncytial.
HSV.
HSV different.
Big difference.
Is it?
Yeah.
Oh, you're a good
There's
doctor.
Vaccine now. I know my alphabet.
Oh.
All 24 letters.
For a second there, I was like, is there 26? Or
Yes, there is.
25?
I know all the numbers. I can tell you.
Yeah?
Each one. 1, 2, 3, 4. Which should I keep going?
Yeah, keep
5.
going.
No, we don't have time for that. So RSV vaccination, does it work? Is it helpful? And what does this study tell us?
So bottom line, at just about 7 months, RSV vaccination prevented 1 case of RSV-related lower respiratory tract disease for every 379 people vaccinated.
That doesn't sound great, but there's a lot of confounders in the study because what if it was 14 months or what if they tracked over a few years? Maybe they would have had better results. Also, this was done in the middle of the COVID-19 pandemic. There was not a lot of RSV going around.
That's true.
It was like COVID-19 pandemic was the only window in time that my kids have not had fever or runny nose.
Yeah, it was wonderful, wasn't it? And now they're catching up.
Yeah.
The days without fever are
Yeah,
more rare.
exactly.
I take them to the emergency room if my kids don't have a fever. I take him in, I'm like, my kid is well today. He does not have a viral gastroenteritis. He does not have an upper respiratory tract infection. His ear doesn't even hurt. There's got to be something wrong
is
with
terribly, terribly wrong. My kids' nose run so much they want to medal for a marathon.
it. Wow. But you know what's weird? You know what's weird about your nose running? Why do your feet smell?
I don't know why my...
Well, your nose should smell and your feet should run. It's always the opposite.
Oh, I get. Okay, yeah.
Yeah.
Pretty complex when it comes to your higher level dad jokes. More like a grandpa joke.
Oh.
What would a grandpa joke look like? We never even asked that before.
I don't know. He couldn't survive your bad dad jokes.
Won't make it to grandparenthood. So let's talk about this study. It was 25,000 adults.
Age 60 or older, and they were healthy, right? They excluded people who had unstable comorbidities or resided in long-term care. They were or immunocompromised. So you're looking at a really healthy 60-year-old who you're talking to about giving an expensive vaccine. It's a couple $100, I think.
And 0.3% of the folks with placebo got RSV. So your baseline number is pretty low. So you need a pretty high-powered study to find out if there's a difference. The folks who did get the vaccine and not placebo, they got RSV at a rate of 0.06%.
Yeah, I think bottom line for me, I'm going to be talking to my patients, maybe if this is covered. Not a lot of adverse events, but am I going to make my patient pay out of pocket for this? Probably not.
Probably not. They did get adverse events, like you mentioned, pain at injection site, fatigue, and the most selfish adverse event, myalgia.
People are so self-centered, aren't they?
Yeah, no one ever complains about your algia.
Yeah.
It's a shame. So what's the next study we want to talk about? This one irritates me
Why?
because it's about irritable bowel syndrome.
Oh, not the patients.
Actually,
The
no, in all
bowels.
seriousness, I love this article because it's
Yeah.
real life.
Yeah.
Because people come to you with IBS symptoms, and hopefully we've excluded the bad stuff. And then we say, try the FODMAP diet. There's a great app from Monash University, the FODMAP diet app. Should have been called the FODMAP app,
FODMAP app.
FODMAP
Yeah,
app.
they left a joke on the table.
unfortunately. So, but then you say, well, have you tried medication? They've always tried something like antispasmodics, and that's the population in this study. 463 patients, just like that. And what did they find?
And so they found that for those patients, your second-line treatment with amitriptyline actually had pretty decent results. And the reason this is a great one because it's real-life medicine, like you said. First line doesn't always work. That's why we have second line. That's why your patients always come to me afterwards, after you fail, to get real medical treatment. So amitriptyline superior to placebo, with 60% of patients having symptom relief versus 45 of those didn't take placebo. Number needed to treat is 7.
That's phenomenal. And once again, we just heard about the most selfish side effect, the most selfish medication. Amitriptyline. So let's move on to this article is of real pain in the neck or low back acutely. Now, if we give these folks opioids, it's going to bite you in the neck.
Ooh, ouch. What else bites you in the neck?
Dracula.
Ooh, that's a dark. that joke should never see daylight.
Yeah, because he's a necromancer.
Ooh, 1, 2.
Very good.
Nice. Okay, but this I think this is a signal article of larger trends where we're seeing opioids not effective short term, long term, with long term adverse effects.
Yeah, it's amazing. Pain was actually worse with opioids at 1 year later.
That's wild.
People, if you gave them oxycodone, their pain score was 2.4, compared to if you gave them placebo, it was only 1.8. So there was no difference in pain intensity if you gave them oxycodone or placebo at 6 weeks either.
Yeah, for acute neck or low back pain. Now, obviously for these patients, we're ruling out any badness in the neck or in the low back, but functioning, quality of life, healthcare use, absenteeism, results were the same or worse with opioids. So this is one that goes back to do no harm.
Yeah, and I mean, we always want to talk about those non-pharmacologic treatments, and there's been great studies for low back pain for, yoga, tai chi, massage, acupuncture. And chiropractic is an option. I personally avoid recommending that for neck pain in case of the very rare but possible risk of vertebral basilar artery dissection. I actually had a really good chiropractic joke.
Oh, did you?
It's not ready yet. It needs adjustment.
Oh, no. Move on to the next article.
You sound like you're having an actual bowel movement. So what do you give to the person who has everything?
Penicillin.
That's right. This next article is for penicillin allergy. And there's a couple great tools. This one talks about the PenFast tool. There's another one called the very creatively named penicillin allergy delabeling tool.
Pad their resume with that article.
This is like a very real situation. You ask your patient, what are your allergies? I'm allergic to penicillin. And you ask, what was your reaction?
I don't know. My mom told me, my parents always said, or I had some sort of reaction as a kid. So really common.
Yeah, my neighbor had a reaction, so I just tell people I'm allergic to penicillin.
I was just sitting there minding my own business. I was just chilling. I was penicillin.
Oh, dear. So this is very painful.
What do you mean?
Just sitting with you and hearing your jokes. But just as a side note, had to say that because of these jokes are so cringe.
But so what do you do for these patients? So this study looked at an RCT 282, gave them either 250 or 500 milligrams of penicillin, and 98% of them were delabeled.
Yeah, so
that's amazing.
It's as safe as standard of care penicillin skin testing. So the process is you do this questionnaire. The PenFast tool, it's very simple. I've used it many times now. I like to print out the results so the patients don't think that I'm just some wacko who's like, actually, you're not allergic. Ta-da! So it's very objective. You ask, have you had a serious reaction? How has it been more than 5 years? Was your skin peeling? Did you have something like Stevens-Johnson's? Did you need treatment? If they say no to all the questions on the PenFast tool, I tell them your chance of having a skin allergy test show that you have a penicillin allergy is less than 1%.
Less than 1%. You can go right back to licking mold off your bread. You can eat moldy bread.
Amazing.
You can eat
And
moldy bread.
that is quality of life right there. That's what
yeah,
patients
that's
really
quality
want.
of life, right? You like want your toast before you go to work, and
Yeah.
you're like, there's a bit of mold. You ever done that? You ever just pick off the moldy bit and then toast it anyway?
I do, with the prices of how much Loblaws is gouging us for groceries these days.
Like gluten intolerance, beef, gone.
Yeah, exactly.
I'm gonna eat this bread, moldy bread.
So great study, because then when the PenFast score was very low, the old-fashioned way was you would send them to an allergist at that point, but this says, why don't you just give them 250 milligrams of amoxicillin,
Yeah.
wait for half an hour, and 98% of patients, they were able to remove their penicillin allergy label.
That's amazing.
It is amazing.
Take this penicillin, go over, be a chillin', and then I'm going to give you the rest of your prescription. But I think as we enter this era of more antibiotic resistance, if we can remove those labels and use those basic antibiotics, I think we're going to be better off
Yeah.
long term.
My wife is very familiar with syphilis, professionally, not... Let me rephrase that. My wife works
You're not helping.
at an STI clinic where she treats other people who have syphilis, not her or myself. Again.
Yeah.
But
Positive
it's-
for life, man.
stay positive.
RPR.
All those memes and inspirational quotes. But they use this all the time there because
right.
penicillin,
Yeah.
your intramuscular penicillin, is your first line treatment for syphilis.
We're seeing so much more, aren't we?
Yeah, and if you say I've had an allergy to penicillin, well, then all of a sudden your good options are gone.
Interesting.
So it's a phenomenal tool. PenFast, I highly recommend using it in your practice.
Quick to use. Some may say it's fast.
Moving on to assessment of urinary incontinence in older adults. And I love this article because they say urinary incontinence is not a diagnosis. If someone's dribbling, you don't just say diagnosis incontinence. No.
Are they basketball players?
The sports medicine article. Yeah. No, the point is we got to find out, why do they have incontinence? What type of incontinence do they have, so we can treat them better?
Yeah, that clinical classification of incontinence is very relevant. So they break it down in this article into 4 different ones. So overactive bladder, it's usually urgency, usually daytime frequency, or nocturia. And then next one, do you want to talk about stress urinary incontinence?
Yeah, this one's causing a lot of angst.
Just thinking about it.
Very stressful topic. Stress urinary incontinence is, of course, when people say, I cough, I sneeze, I have a history of smoking, and then urine just comes out by itself when I'm having some Valsalva. And
Chronic cough, COVID is the worst side effect of chronic cough.
This one might be a bit boring, but the next one is very fun.
Is it? Why? Because it's functional. There's got to be more. Was that your dad joke? You just took the first 3 letters. That's cheap. That's cheap. Continence requires the individual to recognize the need to void. So, like a child? My child would have functional incontinence?
Yeah. And or elderly folks, they've had a stroke. They've got cognitive decline.
Yeah.
They don't know that they should go up and use the toilet, and so they unfortunately soil themselves. An older person restrained by bed rails is another example they give. So,
okay. Yeah, functional incontinence in kids is not fun. The number of times my kid's been too excited to play to realize he has to go wee, and they have a wee accident.
You've been christened by the
Christened
by the liquid of fatherhood.
The liquid of fatherhood.
The many different sprays and soils.
Yeah, I like how it's like he has a wee, but it's me that has to do the cleanup.
Yeah, well,
he's not very involving.
I'm sorry about that fact that your child does what every child does. Overflow.
The Niagara Falls problem.
Exactly. Yeah, there's too much urine in there, and there's some reason for it. And so you see this, folks, with chronic painless urinary retention. You see this in folks where the pressure can no longer be contained by the sphincter.
Yeah, so this is the urethral sphincter being overflown by the increasing intravesicular pressure, small frequent volume voids, and dribbling incontinence.
Now, there's actually a 5th kind, if you think about it. The 5th kind is going to be a combination of more than one of these. And that's actually quite frequent as well.
Okay,
They don't have list a rate or amount. But that's why when you see these folks, you got to ask them about the storage symptoms. Are you having urgency, frequency, nocturia, stress incontinence?
So this article comes out with a great mnemonic. Diapers, diapers, should be considered. So patients with new onset, and you're going to assess them. What are you thinking about using this diapers
D is for
mnemonic?
delirium, I is for infection.
And then infection, they put a special note about avoiding treatment of asymptomatic bacteriuria, and then atrophic
Traffic.
Atraffic vaginitis.
Your
'cause
mind
there's
is stuck on
nothing,
your commute.
Nothing going on down there.
Atraffic.
Atraffic vaginitis, which has now changed the name to genitourinary syndrome of menopause. And then pharmaceuticals, and they give a big list here.
It's a huge list, but honestly, you can summarize it pretty closely down into antihypertensives and psychiatric medications. So specifically,
Oh, okay.
ACE inhibitors, calcium channel blockers, diuretics as antihypertensives, for example, as well as your alpha agonists and antagonists. And then psychiatric drugs, psychotropic drugs, lithium, and SSRIs.
So that's a great way to break that down as you get to the middle of the diaper.
Mm-hmm.
So those are your number one things that you're thinking about.
For number one.
For number one.
Yeah.
Should be top of mind, top of diaper. Psychological excess urine output. I've had a few patients with this who've tried different medications, and then you go to a house call, and they're walking around with one of those Stanley mugs.
Oh, wow.
It's en vogue right now.
Yeah.
Do you use one?
Stanley tumblers. I don't
Stanley
watch
tumblers.
TikTok anymore.
Oh.
I've now recovered.
No. Yeah.
I do not know about the latest trends like
Yeah,
Stanley
so
mugs.
it's just they're drinking a ton of water because they're thirsty, and that's sometimes the cause.
Hydro homies, keep it real. It's a thing.
Is it?
Oh, yeah.
Oh, okay.
Where are we at now? Reduced mobility and stool impaction.
stool
So that's
impactions.
why physical exams should include a digital rectal exam.
There you are. You put your finger on the diagnosis.
Yeah. So complete physical, complete history. Just going back to the history, you want to ask about the storage symptoms, ask about the voiding symptoms, ask about the post-micturition symptoms, and then, get a medication comorbidity list as well.
Brilliant. So that's great. Now I'm excited. What's going to happen to these patients afterwards? You're going to bring them back.
We're gonna.
What if you're successful in treating them?
So I don't know because this is part one, and they haven't released part two of the article. But actually, I'm assuming part two is going to be treatment. They're probably going to talk about medications and probably non-medication options.
I'm doing one of them right now.
Really? What is that?
That's a Kegel.
Oh, wow. Actually, some of you may not know this, but Paul's actually a very accomplished Kegelist. Is that
Kegelist?
the term
Yeah,
you prefer?
it's kind of it came out of some gymnast activity
Okay.
that I
And
did
you've-
before. Yeah,
And you've competed, right?
I can be international Kegel competition.
The ick competition.
Yeah.
And what's the mass?
They don't televise it because it's just not that entertaining.
No, it just looks like this.
Yeah.
What's the mascot of the Kegel?
It'd be the Kegel Seagull. Kegel Seagull, yeah.
All right.
He's conveniently got fecal incontinence whenever he flies over you as well.
Right?
Yeah.
No lineups for the bathroom at the
Nope.
Kegel competition. So let's wrap up with this game-changing article. So this one is huge. Just came out this month from the Journal of the American Medical Association, April 2024. Because in 2021, a group of scientists made a public statement and said, hold on, you should forego acetaminophen during pregnancy because of the risk of ADHD and autism. So they said, forego acetaminophen unless its use is medically indicated.
Why else would you be using it?
Because it tastes good.
I don't think it does.
Some have the sugar coating.
Do they?
Oh, you must buy the generic.
I buy
version.
the generic.
Yeah, if you get the
one, yeah.
brand version.
Oh,
delicious.
oof.
Yeah,
Give it to your kids and stuff.
yeah. I'm
Is it a
turning
treat?
a lot more yellow lately, but other than that, I feel great. No pain.
Teaching kids the colors of the rainbow
Yeah.
using for failure.
So no, that definitely is a failure of concept right there. So these folks, and understandably, if someone is pregnant and they say, I've got pain, and you say, well, there's no good options. NSAIDs are not great at term. And now we say Tylenol, we said this in 2021, might cause autism, ADHD. So tell me about this study. How was this one structured?
So this one was quite a large N. Was it 2 million?
2 million.
2 million.
2.5 million.
2.5 million. So that gives me some clinical confidence.
Yeah, and then they
Where was it
followed
actually?
them up
Was it in Sweden?
for years.
Sweden.
So this was from 1995 to 2019.
Wow.
And then, they included all the children born in that window, and then they followed them up until 2021.
Okay.
So some of these kids had,
some kids for ages. So they would have
years.
picked up if there was ADHD.
yeah,
Yeah.
definitely. And
And
it was-
what did they say? What did the study say?
no,
No. Okay.
there's no association. So
Amazing.
massive study. So why did we have that kind of a signal suggesting that there might be autism, ADHD associated? Well, they said it was probably because of what did they say, sibling co-founding.
Oh.
So those older
That
studies
when you
didn't
make
have
twins.
They didn't have sibling control, and so it was the co-founding that was the cause.
Co-founding siblings.
Exactly.
How do you co-found siblings?
I don't know. I lost.
You
my
lose them
kids
both?
a while ago. Haven't seen them in a while. I think that is a wrap for April 2024. Dad Joke Medicine. That's right. This is Family Med Distilled.
And this is Dr. Paul Dillon signing off for Dad Joke Medicine. We'll see you next month.
See you next month. Take care. So it sounds like a boy band.
NSAID?
All right. What episode number is this? I don't even know.
Great start. Let's go. Dive
welcome
in.
to-
Simon, why don't you introduce this one?
Welcome to this episode of Dad Joke Medicine. We are so excited that we don't even know where we're at. What are we reviewing today, Paul?
We're doing CFP Journal May 2024.
That's right. So why don't we start with, as we always do, the cover critique for the CFP Journal.
What this reminds me of, I see all these different pills. It's the patients coming in and say, I'm on the blue pill, on the purple pill, doc, you know which one that is. And I never do.
No, I give them that look. I'm just like, you know that pill has like 50 generic forms? I have no clue. I'm so sorry.
You just know that one small blue one.
The small blue one.
Yeah.
I don't know what you're talking about.
Don't know what I'm talking about? Excellent. Nice.
I'm
nice
like
answer.
here on this map where I'm completely lost when it comes to medication.
But you know what would be amazing? I thought about this recently. I'm like, what if doctors had to take their own medication?
Oh, yeah?
Yeah. Like a urologist, a bit of Flomax, a bit of Cialis.
Oh, that's the...
You never know. Psych. Can you imagine a psychiatrist
combination.
wakes up in the morning, has to take all the medications they're going to prescribe that day?
Oh, my gosh. I'm going to take the Zopiclone. I'm going to be asleep before I even see my first patient.
Cardiologists, I don't even think they'd make it to work. They'd be so hypotensive.
That's incredible.
So let's go on. Like there was a couple of good articles this month. What was your favorite one?
Yeah, so my favorite one is the migraine one for sure. So
That one gave me a headache.
big headache for that one, but no, I gotta say that one is, I can sense it coming on. I can feel.
Wait a second. I think you kind of had an aura.
Yes.
About, oh my God,
Yes.
no way.
And that article is
Okay.
not horrible. I can guarantee you right now. Come on. That was a good one.
Slow clap to start.
slow
Amazing.
clap,
So
slow
let's
burn.
dive in. Now, I think I agree with you. Out of all the articles, this is a banger.
Oh, we're gonna start with it.
Yeah.
I'm so
Let's start
excited.
with it. So it's RX Files from Saskatchewan, where I did my residency training. So two good things to come out of Saskatchewan: RX Files and myself. Medicare.
Crickets.
Medicare. That's three. Come on.
Medicare.
So let's dive in. Come on. You got three authors. RX Files. They did some clinical detailing, and they came up with 10 pearls. I think 8 are real hits.
Pounding pearls for migraines.
Pounding pearls for migraines. Let's
So-
pound through it then.
So there's actually some really useful clinical stuff in here.
Yeah.
When you've got a patient who is having migraines and they're going to come to you and they're going to complain about the medication.
Yeah.
They're going to say, I don't like this medication because, and this article is chock full of treatments and next steps we can do.
Okay. So give me your top one out of the 8. You know, start off with the long-acting versus. So this was a little bit new to me. Long-acting versus short-acting triptans.
There's 2 migraine triptans that you're going to avoid.
Okay.
And it's easy to remember. So frovatriptan, you're going to forget about that one.
Okay. Yeah, love it. Love it. Okay.
And naratriptan. What do you think about that one?
Narrow again.
Nara
Nara
again.
again. Never again.
Nara's going to give naratriptan. And why is that? It's because they're slow acting and they take a long time to build up in the serum level. And it takes, sometimes even 2 or 3 hours before they kick in.
Wow. Okay. Okay. So that's fair. But there was a note here. Due to the longer half-life, frovatriptan and I'm tripping over the words. Frovatriptan and naratriptan
Nicely done.
have evidence for twice daily dosing in the prevention of menstrual migraine. So that's a unique indication. Maybe it'll show up on an exam or something. Which triptan would you choose?
Exactly. And I think there's a second role for these. If the folks who they take their triptan and they're overwhelmed with nausea. They get the side effect before they get the effect. And so the good news is these slow-acting triptans are the long-acting triptans. They're going to help you out with reducing those side effects.
So important to get people to get these medications on board right away. 1 or 2 of these tips talks about that. When you talked about empty stomach, I immediately thought of number 2.
Number 2?
Yeah. The number 2 point, Simon.
The second point. Oh, the
number
second
2
point,
point.
yes.
So this was
it's not something I would have thought about. You would think, like, someone's got some migraine symptoms, nausea, and they think, oh, maybe I'll snack on something. Taking NSAIDs on an empty stomach.
No, that sounds like
Do it.
malpractice.
Yeah, I know, because I'm like, reflex to almost say that to patients as part of their advice for the medications.
Right, yeah.
30 minutes faster onset. So if you eat and have NSAIDs, it takes up to 60 minutes. So for our migraine patients who you're saying, like, take some medication right away, whatever's available, maybe they don't have their prescription, take the medication on empty stomach. NSAIDs will kick in about 30 minutes earlier, 30 minutes faster.
That's amazing. That's a really practical pearl for NSAIDs.
Not been said before. Or NSAID.
You've said it here first.
Ooh.
All right. It sounds like a boy band.
NSAID?
All right.
That's good.
There's some DUI jokes in there that are very timely that
I feel like we're in sync right now.
Oh, there it is.
No.
Okay. So you were very excited about this other option for giving triptans. Folks who, they get nosebleeds after they get the intranasal. The pills take way too long. How do we help them?
So this is because I wouldn't think about doing this in my community practice, but in the hospital, doing subcutaneous sumatriptan. Now, there's a cost for the tablets, but in the ER, maybe, it's another option to think about, subcutaneous sumatriptan.
Exactly. You just love getting under people's skin, don't you?
Nice.
There's some other amazing pearls here. So other than that one.
That one was interesting. So in other medications, so metoclopramide, use it quite often in the ER, shows up in our power plans for migraine patients. But getting that to patients in the outpatient setting, so giving them a tablet, something I hadn't always thought about, but something to think about. Use it all the time in the ER, but not always in the clinic.
Yeah, so giving them Maxaran, brand name generic, is going to be metoclopramide. The huge benefit of that is it slows down that gastric emptying. It gets rid of some of that nausea side effect of the migraine that they're having anyways. And it turns out that it boosts the effectiveness of the other analgesia.
Amazing. And now we've talked a lot about the triptans already. What about your pants? I see you're not wearing any pants today.
Well, you took
Where are
your
your pants?
pants off. So,
I took your pants off. There's two kinds of Japants, I think, in Canada. Is there?
Yeah, so there's some that we use for prevention of migraines, and those I believe are injectable. And then there's other ones that we can use for treatment of migraine, especially in people who have really high risk for using triptans. We're talking about the cardiac patients.
Okay, and so that's one good thing to think about. But the other key point here was your risk of serotonin syndrome. If the patients have a triptan and on an SSRI, is actually quite low. So something to mention to patients, but not as concerning unless you're in an exam. Then maybe you're going to say, watch out for serotonin syndrome.
Yeah, and there is one interaction that you really got to look out for.
Which one?
That's MAOIs. You got to keep your eyes on the MAOIs.
Ooh.
So MAOIs and triptans, that's going to trip you up on your exam because that is an absolute contraindication due to high risk of serotonin syndrome.
Interesting. Do you teach medicine?
I do, yeah, and I've also got 3 kids, which is why the dad jokes are just rolling off the tongue right now, like a sublingual medication.
A sublingual medication, like what?
Like I don't know.
Which one are you thinking of?
Are you thinking what I'm thinking? Moving on.
Slipped off. It was on the tip of my tongue, but it's gone now.
There is a great option for Halloween, I find.
Oh yeah.
Your patient is having migraines and they want a medication to prevent it. Well, at Halloween, you're just going to give it out freely.
All you give is candy at Halloween.
That's right, Candisartan.
Really?
Candisartan.
Candisartan.
Yeah, so they say add that to your list of migraine prophylaxis options. I mean, you know the rest of them on here. You know the ones that you love.
Oh, the ones that make me laugh out loud.
The LOLs.
The propranolol. Propranolols, metoprolol, the world's funniest medication.
Amazing. And then there's the amitriptyline, the nortriptyline. There's a long list of options. So I always tell my patients, migraine can be a real pain. No pun intended there. But stick with it. There's lots of options to help you try and get over this.
There's a great other website in here, migrainecanada.org/diaries. I always tell my patients I want a written diary, what's been happening with your medications. So migrainecanada.org. It's a bit of a headache to spell it and get to the website, but sight for sore eyes.
I see what you did there.
Ooh.
Let's talk about this diabetes calculator.
Oh, let's go back. Yeah. Another great resource. So 2 great resources this month.
So this is one I pull this up with my patients when they come to talk to me about diabetes medications. Because no longer am I talking about some abstract, like, well, we'll get this number down on your blood test. Like, nobody cares about that.
Some patients do. I have the occasional one who's like laser focused, more focused than I am on their hemoglobin A1C. And the problem is you got to be careful. You don't want to get it down to 0. You got to say, like, we have a range we're going for, not just the lowest hemoglobin A1C that you can get.
So this is a really cool article because it's hidden in the article. It took me a little while to find it, but there's a phenomenal calculator.
Yeah.
And
boom.
I've started pulling this calculator up with my patients, just like I do with the best CVD risk calculator from the same group. And we punch in the variables.
Yeah.
And then we say, what's important to you? And there's actually a question there. Do you want to not have a stroke? Do you want to not have a heart attack? Or do you want to have normal pressure sensation on the bottom of your feet?
Which you have to explain to patients, but that can be, I always have to check my patients when they come into the ER. Diabetic, you want to get their socks off. My pro tip is always get your diabetic patients to wear white socks, because when they take it off, they can see if there's a bleed or an ulcer on the white sock.
It's a great pearl.
White sock lobby.
How many shares do you
Paid for,
have in
yeah.
the white sock industry?
I don't know. I have a few pairs.
Sorry.
A few pairs of shares.
Pairs of shares. Worried about your textile texts that you've been receiving. Okay.
Come on, let's sew it up.
Pull up the calculator with your patient, and you ask, what are your values? And then show them how this medication can change your variables.
I'd be interested to hear what like how do patients really rank, like heart attack versus stroke versus can't feel my feet. I don't know. I'm intrigued. There'll be another study. There'll be another paper on that. We could be in the top 50 publishers, maybe.
Oh,
we'll come to that in a second, won't we?
I cannot wait.
Kept that for the
to
end.
see your seething jealousy from the top 50 researchers in Canada.
There's some lists I want to be on and some I don't want to be on as a physician.
Let's talk about the cranberries.
Oh, here we're talking about controversy. You talk about the sock lobby and the textile lobby.
Yeah,
What
we're
about Big Cranberry?
Big Cranberry. And we're not talking just about the Irish rock band.
Oh,
We're talking about UTI prevention. That's right, urinary tract infection prevention. This is an update that is burning with urgency.
oh. Burning with urgency? Did you just hide a dad joke within a dad joke?
The double dad joke, yeah. It is an occult dad joke. It's like a Ouija board dad joke. Do you have one?
So here's a real question. Do you say this to your patients? Before you read this, if I took this article away, I came in with another UTI as a female, pregnant, maybe not, elderly, young. What would you say? What do you say? What about cranberry juice, doc?
Well, they've already
I've heard
taken
about
it. By the time they see you, they've already had their...
Say they've had 10 UTIs. You've eliminated everything else. And you're like, prophylactic antibiotics. They say, no, doc, I want to try cranberry juice. What do you say
argue
to
with it. I mean, in vitro, the science is there. It shows that there's reduced adherence of the bacteria on the bladder wall.
I could just drop science on this. In vitro. In vitro, in utero. What about...
Well, that's why I'm a
what
in
about
vitro VIP.
In clinico.
In clinico. How do we actually talk to them about
Yeah, real life.
The problem is most cranberry formulations are full of sugar. Okay. You got your cranberry cocktail, your cranberry juices. And
cranberry vodka.
if you eat plain cranberries, it's just going to be just puckeringly sour.
Okay.
Like eating any cocktail that you've ever made. It's just like disgusting.
I don't think I've ever had a straight up cranberry.
Well, there's a reason for that. It's because they taste awful. And so patients are not going to want to eat plain cranberries. And so probably the best formulation for minimizing all those problems is going to be the cranberry pills.
So the cranberry pills, if your patients are asked, but still not great evidence. I think it was like 18 to 24%. There's a tiny reduction. You know what works better?
What's that?
Water.
Oh, no kidding.
So H2O. So yeah, drinking 1.5, is it 1 or 1? Yeah, 1.5 liters causes, this is great, 1.5 less UTIs a year.
Wow.
I don't know
Easy
what
to
you do
remember.
with that 0.5 UTI. Like, is it or is it not?
You have it on it starts on December 28th.
28th. Yeah,
half
it's
of
just,
it is
you
this
have
year?
half a UTI. It's like having half a pregnancy.
Yeah.
Is it there or not?
Not-
Is
not
or is
there.
not? Come on.
Well, I'm sure your
Some
patients
rounding.
love you when you just tell them drink more water.
Yeah.
Real good one. You know, your UTI advice may be bad, but mine is bladder. The bladder, the better.
A moment of silence for that. That was stunning.
Just like you were just
That's
like in shock.
stunning.
How horrible that dad
Wow.
joke was.
But yeah, so low dose antibiotics provide the most effective prophylaxis, but may be associated with some side effects.
That's great. I think that we flushed this one out.
Ooh, let's go on.
It's the end of that stream of consciousness for the urinary stream.
Let's stop this. You cannot
Finish
go
that one
any
off.
further.
Okay.
Oh,
Moving on to...
you're gonna be up all night thinking about that one.
Moving away with urgency to this research article.
Super quick one. This is brilliant. This is like This is like getting your resident research project done in a day. Now, that being said, they got 5 authors who did a Google search to find out who the 50 most cited primary care researchers in Canada were. Are you on the list?
Oh, absolutely not.
Yeah, I didn't think
No,
so. I've seen your research. But yeah, top 50 list. And they broke it down. You can see what's going on. If you know what, if you're listening to this podcast and on this list, no, wait a second. There's a very low likelihood.
I'm pretty sure Dave Davis with
Davis.
18,551 citations is probably writing more research and not listening to this exceptional podcast.
I don't know. I'd want the player trading card for Brian H. Rowe. 27,155 total citations.
There you go. And the number 1 university affiliation.
Oh, where? I'm intrigued. McMaster. I'm going to bet it's McMaster.
No, they're 5th.
Oh, what?
Yeah, let's get the rivalry going.
Count this up then. I was going to go McMaster.
Yeah. What's number 4? You're not going to guess this one.
University of Ottawa.
No,
Rules,
they're
Ottawa
not even
rules.
in the top
No
7.
way. Oh, okay.
Number 4 is Western.
Oh, home of family medicine. Okay,
Yeah.
sure, but only 4.
Number
So
3.
there's 3 more ahead. Oh,
UBC, our alma mater.
okay, nice. Yeah,
Somehow
yeah.
they made it there despite having us on the alumni list. Number 2, je ne sais quoi.
Oh, McGill.
You got it.
Yeah,
there you go.
McGill. Okay.
Number 1
what's
is
number 1? Hold
just
on.
who you think it is and who they think it is too.
University of Toronto.
Yeah. Okay, moving on. Next topic.
What else? We're done. We're almost done.
There
We're
was
into the advertising.
nothing interesting in the ads, is there?
You know what? I always love to have a look. I'm probably one of the few people that actually looks. It's always kind of going like, what else is going on? But my favorite one, beautiful Oceanside, White Rock, BC. Locum and permanent positions available.
Oh, what's interesting about
And
working in
then
White
what's interesting about it is then it lists 4 different ways to get out of town. 45 minutes away from here, 10 minutes to the U.S., 3 hours to Seattle, 2 hours to Whistler.
So they're saying if you would rather be in the U.S., come work in White
Come
Rock.
work in White Rock. There's lots of ways to get out of there.
That is
amazing.
Well, I think we've wrapped that one up for May 2024 CFP Journal.
Some
and that
great stuff in there. We had big cranberry, we had diabetes, and we had the migraine.
Migraines.
Migraine. Great websites, a couple new ones. That's great. Until next month, Simon.
This has been Dad Joke Medicine. We'll see you next time.
Too dad.
All right.
Come on. Here we go.
Oh, I know. Sleep medicine. Snoozing wisely. Boom. Welcome to Dad Joke Medicine, episode 5.
Here at number 5, we have the CFP Journal. I've torn out all the non-clinically relevant stuff. So it's looking a bit light, but it's not about quality, it's about quantity.
And they...
Is that right?
Wait a minute. That's the opposite. So this is the June 2024 version, and that is right. It is the 70th anniversary edition. Speaking of quantity.
Speaking of quantity, they went down to one color as well, blue.
Yeah,
All matches.
their budget is going
They
down.
have an old bulletin. I can read the College of General Practice open bracket medicine in Canada. They have a seminar on alcoholism, symposium on non-gonococcal urethritis, and then they get right into the business approach to starting a practice. 1, 2, 3.
We're still struggling with the same content in 2024, 70 years later.
Yeah,
guess
starting
that-
a practice. That's true.
that-
That's still something we deal with today.
Yeah, that is our cover critique. So let's move on to not just the medical updates, but interspersed, as always, with dad joke content throughout.
Interspersed
So
everywhere.
in this-
Beginning, middle, and end.
In this video, we're going to be talking about screen time in children.
Oh, amazing. Yeah, we're going to talk about some of the parent-centered outcomes around screen time in kids.
We're going to talk about choosing wisely, recommendations on type 2 diabetes in older patients.
Amazing. So that's 2 big ones. I just couldn't get excited about this last one.
Oh, that's right. We're going to wrap it up with tools for practice, medications for apathy in dementia.
Sigh.
So let's get started. All right. What is the first article here?
What do we got here? So screen time, sleep in children. This is by Randy Goldman. He does articles almost every month, so about 10 a year. So we're going actually down to 10 CFP journals a year now. Yep.
Okay. Next
They've
one's going to be a combination.
Combined July, August. Single one in the summer because you're so busy. And then November, December as well. Bringing it
Cutbacks.
down to 1.
Unbelievable. Speaking of cutbacks, it's time that my kids cut back on their screen time so they can get a good night's sleep. More importantly, so I can get a good night's sleep.
When you were talking about cutbacks and kids, I thought it was like a circumcision joke.
No, definitely
I would have
nowhere.
cut you off. Inappropriate.
All right, so
Okay, so why don't you give the forward on this one?
the forward on the screen time.
Yeah.
Was there a joke there? Because I totally missed it.
You'll go back and watch this afterwards. Just roll it back.
The forward on the foreskin. Is that what you're getting at?
No comment.
There's nothing to do with circumcision.
Nothing. Come
How
on.
come everything with you ends up being about circumcision?
Okay, come on. Let's concentrate. We're
So
about
screen
learning.
time, it is about bedtimes. We're not going to make any blanket statements. Yes, that's right. That is the sign of an exceptional dad joke.
Where
Can't
do you
even
get
contain it.
Where do you get this stuff?
From being a parent?
I thought you got it from the database.
The database.
Boom.
Thanks
Come
for
on.
the setup that I totally just like whiffed on. Swing and a miss. All right.
So I continue to hear concerns about parents in my practice about the frequent use of light-emitting devices.
Unbelievable. Can you believe people with their technology and their stuff?
Light-emitting.
None in my house.
My God. Light-emitting devices like a light bulb?
Yeah. Photons just coming at
Turn
you.
off the lights so kids will go back to bed.
Oh, wait till you see the recommendation on caffeine before bedtime.
Oh, right. Yeah, caffeine in kids. Ooh, hold on for this breaking
Yeah,
news.
it turns out you shouldn't give
so-
it to them right before bed.
So bottom line, I'm going to go to this. No screens, lighting emitting devices for an hour before bedtime. Is this groundbreaking or what?
I mean, we've kind of wrestled back and forth. There was the whole like no screen time before age 2, and then COVID happened, and suddenly we looked at the research differently. We're like,
Free for all.
yeah, we're like
Became
we're-
appropriate. Canadian Pediatric Society came out with a guideline that said like appropriate use, that you can use it to like call your grandparents and that. But I think we're seeing a swing back to saying less screen time, more quality, and definitely relating to sleep, not before sleep. My kids go mental. Yeah, with screen time.
Oh gosh,
Yeah,
yeah.
right before
It's like
bed.
it's like they could always want more. And it turns out that there is research showing that it does affect melatonin levels. They've measured this.
Yeah. And they used, this is the greatest part, Children's Sleep Habits Questionnaire, delivered by iPad.
So now that you're about to go to sleep,
Confounder in that
turn
study.
on the iPad. So what is the bottom line here? Do not use any screens 1 hour before bedtime. For
Yep.
the kids. For
For
you,
the kids. For you, totally fine. That's the reason I get the kids to bed, is so I can have some screen time. Got to go do my results at
well, I
home.
can quit whenever I want.
Yeah.
I
Oh,
would
yeah.
be fine without
Yeah.
my necessary wind down time of 2 hours of screen time
Cold turkey off the television.
in bed. There actually, I saw a good video about cold turkeys.
Yeah.
And I was trying to fall asleep last. Dang it! So, all right, we're almost done. Should we quilt while we're ahead, or should we talk about?
Did you say quilt? Quit.
Yes, that's right.
Quilt.
while you're
Bedtime quilt. Does anyone quilt anymore?
ahead. There are 4 other fantastic tips for
Oh.
helping your kids fall asleep.
Oh, important for new dads, new moms out there.
Yeah, we don't
Sort of
we don't
advice.
read journal articles for the medical advice. We read it for the parenting content.
Yeah,
That's
yeah.
why we're here as dads.
Parent-oriented outcomes. This is it. So you know what would work really well if you read this article to your kids.
Yes, they will fall asleep. So read to your kids at bedtime.
Reading at bedtime, we got that low light and noise. And what's this next one?
Yeah,
You
do
mentioned?
not give your kids a Monster energy drink immediately before bed. Who knew that that was good sleep
Have you ever
advice?
done that?
Why would I ever do it? Based on the look on your face.
No comment. Is someone recording this?
They were literally sitting in front
It
of
was
you.
it was non-accidental caffeine ingestion.
Oh my gosh. Maybe on like
I just wanted to see what would happen.
maybe on a holiday.
Not good things.
And then this one is going to break some little hearts, but if the child sleeps in their own bed and not the parent's bed, then there's better sleep for all.
It doesn't actually say that. It talks about child sleep outcomes, but it's definitely better
Definitely
for you
better
as
sleep
well.
for all.
Yeah, let's move on.
Yeah, we'll put that one to bed.
Put that to bed. Put it
Put
to
that to
sleep.
bed.
Put it to sleep.
Put it-
I said it first.
put
You can't have the same dad joke as me.
It's obvious it's not. Okay, moving on. Optimizing.
Oh, here we are. So,
Bringing
type 2
Optimus
diabetes.
Prime to type 2 diabetes care.
so what are we doing? What we're back 10 years ago, went through med school. It was, we got to hit these targets. We got to get these hemoglobin A1Cs down, down, down. Once again,
so
it's
this
like
is
a band.
a type 2 diabetes article for
Baby,
older
are you
patients.
Down, down, down. Is that a song?
Are you singing or are we doing a podcast? So speaking of songs that none of your 65 or older patients would recognize,
Yeah.
Let's talk about optimizing type 2 diabetes care in our 65 and older patients.
So what are we going to do? We're going to talk about maybe changing the medication, maybe dropping some of the medication and giving them a little bit of a higher treatment goal or a target. So some of these for patients in poor health, hemoglobin A1C up to 9.
Yeah. I mean, I remember
That
in
sounds
med school.
malpractice-y.
Yeah, no kidding. The goal for everyone back in med school was 6.5. Make sure that you're
Yep.
like physiologic. Okay, probably 7. But now things have just gotten like they were.
Things
in the
got
70s.
sweeter.
Things just
Yeah.
got chill.
We're back at the Woodstock of diabetes management.
That A1C number just goes up year after year after year.
Year after year. But it's hard.
It's
'cause
like
you
it's
start-
like inflation.
Oh, hemoglobin A1C's gone up, inflation has gone up,
Target's
and then
gone
but
up.
you can actually save money because you can go off medication.
Yeah, so for your patients in poor health, it's okay to have a higher A1C. Then you can avoid hypoglycemia. Then you can avoid polypharmacy. All these things that actually really matter to patients.
This can be challenging. I know I have one patient where he's been stable on his medication for so long now, and you talk about taking medication away. You spent 40 years of your patient relationship saying you got to take this medication, you got to take this medication, it's going to make you live longer, and then you start saying, well, now we got to take it away, it's going to make you live longer. Like, what have you been doing for the past 40 years?
Who are you? I don't even recognize you.
Yeah, I know. I want my old GP back.
So this was a really interesting Choosing Wisely Canada campaign. They really, I guess you could say, they wise to the occasion.
Boo.
Come on.
Wise to the occasion.
It's a good one. There's a
So
couple other
choosing-
good Choosing Wisely campaigns.
There were some that actually didn't make the cut.
Yeah, I
What
think
was one? You mentioned one to me. I don't remember it
The
now.
dental campaign,
Okay, choosing wisely for dentists is what?
Chewing Wisely. Oh, come
I
on.
can only see one person laughing. There's got to be another one. Give me one more. Go for it.
Hematology.
I'm ready. Okay, what does hematology say?
Bruising Wisely.
Ooh.
Come on.
Okay. I'll give you 2 dads on that one.
Okay.
2 dad ratings.
All right. Here's a
Come
good
on.
one.
Here we go.
Oh, I know. Sleep medicine. Snoozing wisely. Boom.
Oh, I think we'd leave it at that.
Yeah.
That's
so
enough.
If
1,
your
2,
patients
3.
are getting older, their health is declining, don't be afraid to let that A1C number just float up.
Float up
Target A1C.
to heaven. Like your patients.
Yeah, you should maybe just exhibit
No.
more apathy when it comes to their A1C.
Oh,
Notice that?
nice. Good transition. Well done. Medications for apathy in dementia. It took 4 people to write this article. Not apathetic. So tools for practice top. I'm sure a lot of people will be getting this by email. So the clinical question they ask, patients with dementia, how safe and effective are stimulants, antidepressants, and antipsychotics for treating apathy?
Yeah, I had a patient
These are elderly
with,
patients.
severe dementia and
Yeah.
apathy. And do you know why he went to therapy?
No.
He didn't. Because of his apathy. Oh my gosh, okay. That's the sign of a good dad joke when you have to explain it to the child.
Yeah. It's a great dad joke, but a poor dad.
Yes, exactly.
I'll
There's
work on it.
no patient advocacy organization for patient apathy. They just couldn't get around
They've
it.
tried again and again.
Nobody cares.
Never. It's just
People have just stopped caring. So this
chronic.
is actually a really serious issue when you have an elderly patient and they've got dementia and they end up with apathy.
So this is it. So methylphenidate, the bottom line here is methylphenidate may improve apathy scores by a small but potentially clinically meaningful amount compared with placebo.
Yeah, so what they did is they followed these patients for 12 weeks and they gave them a questionnaire with 72 points on it saying basically how apathetic are you?
How many of them finished that 72 point?
Yeah,
that's the actual test.
Yeah.
Yeah, what's your score is if you actually make it to the end.
Okay.
I've barely made it to the end of 72
So the folks
question ones. As if you're a medical student.
Yeah,
Can
fair
this?
enough.
Can you give methylphenidate to medical students who are apathetic?
They're all on it now.
Are they already? Oh,
yeah.
Confounder.
Yeah.
Okay.
So 5 points on a 72-point scale. That's how much apathy improvement you get when you give methylphenidate.
Low dose though, isn't it? It's small. Just is it a teeny bit?
Mhm.
Doesn't improve their cognition. Makes them less.
But for those of you who are wondering about the non-pharmacologic treatments, there's several.
Oh, okay. So they talked about sensory stimulation, music therapy,
Singing.
You have a
Okay.
great voice
Thank you for
for a doctor.
stepping.
Pet therapy.
There's a lot of good singing doctors. Don't you remember
Who
the
is there?
choirs during COVID? Why did those end?
The choirs.
It was like the Zoom calls of 80 people singing.
No, I thought you meant like the Seattle outbreak that started with the choir. There's got to be some great bands named some doctor bands. Doctor Who?
Doctor Who?
Is that a song? That's not even a band.
I know Metallica has a song about apathy.
What's that one?
Nothing else matters.
Oh.
All right, moving on. Cognitive
Okay.
stimulation, another great non-pharmacologic treatment. Cognitive stimulation and pet therapy.
Okay.
You feel better now? Do you care more?
I really want to move around and
Care
get
about
away.
That's it for Dad Joke Medicine. We're so glad you joined us.
70th anniversary, 5th episode for us. Hopefully we'll make it to 70.
In your diaper. If you drink less fluid,
Yeah?
you will leak less urine.
What?
Bam.
No. No way.
In this video, we're going to be talking about approach to STI testing in men who have sex with men.
We're going to talk about urinary incontinence in the elderly, part 2.
And holy guacamole, you are not going to believe this article about avocados and IUDs. I cannot wait to
Can't
explain
wait. We are going to smash that one.
like a good avocado article.
So here, let's do something a little bit different today. We always talk about the cover first.
Mm-hmm.
I'm going to read the very first sentence. The very first sentence from the deputy editor, Sarah Fraser. I'm not going to read it in French. I'm going to turn the page here. And then you got to guess what the main topic is.
Okay.
And just dive right in. Don't wait.
Okay.
If you are reading this editorial in print, the journal might seem a bit thicker than usual.
This article is about access to sexual health care. So our first article is about men who have sex with men testing for sexually transmitted infections.
So we're getting more and more complications with sexually transmitted infections. You have to broaden your differential. We've seen Mpox, formerly known as monkeypox, so now it's just Mpox. Just a vernacular change there. And nice article lists everything in our differential diagnosis considerations for male patients described. So what's your takeaway from there? What's your big one that jumped out at you?
It's different. It's absolutely different. So I remember in med school, we were taught, your patient comes in for STI testing, you're going to get your HIV, hepatitis, your syphilis.
Which is an island chain off the coast of Vanuatu.
Okay, I
Hepatitis.
would believe you because my geography is terrible. So HIV, syphilis, hepatitis, and chlamydia and gonorrhea, and that's it. And that is extremely outdated, especially in this higher risk population.
So 3 things you want to be thinking about: shigellosis, another great diagnosis; cryptosporidiosis, Campylobacter, E. coli, salmonellosis.
Didn't know you were
There
rampant.
we are.
Well done. But beyond that, though, there's also different sites. So we don't just do like a urine, chlamydia, gonorrhea. So specifically, they mentioned any mucosal membrane, genital tract, pharynx, or rectum. And as the guy who gives the red eye talk, I must point out that you can also get pink eye from chlamydia or gonorrhea.
Interesting. So just overall broad strokes. The big things to remember is just think about different sites and think about different infections. So broaden your diagnosis, and it's a great little chart here. Table 1, clinical review. Maybe we'll throw it up on the screen.
Really expanding your knowledge on this one. Yeah, I mean, my wife works at the STI clinic at the BC
Is that
Center for
where did
Disease
you guys
Control.
meet again?
At the STI clinic at the BC Center. No, didn't mean there. But that's when the time comes for me to have the talk with my kids. That's
Yeah?
how it's going to go. I'll
Oh,
say,
but
son or daughter, chlamydia
Yeah.
is a reportable illness. So if you ever get chlamydia, your mom's going to know before you do. And that'll be the talk, more or less. So,
it's like come home and you're like, Mom texted me today.
yeah, exactly. Yeah, you heard about it from mom first.
Oh no.
Now,
That's a great way to just put that conversation on the other half.
on the other half, yeah, mom's going to have to do it. There was a part 2 about number 1 in this journal.
Oh my God, part 2. Is there going to be a part 3? What's number 3 if there's number 1 and number 2?
Number
I don't
1
know.
and 2. So we're talking about urinary incontinence. in
Okay.
case you aren't as potty-minded as we are. So this is part 2 in the July-August edition, and some of you may be aware that part 1 leaked earlier in what, June?
Who leaked it?
April. I believe it was in the
Someone
April
leaked
CFP
it to the
Journal.
media. Amazing.
So how should I treat urinary incontinence UI in older patients with frailty?
So bottom line, robust older adults. I'm not sure if there's a robustness scale of older adults. With urinary incontinence should be treated similarly to younger adults. So the same. Is that what they're saying? That's
Yeah.
it.
And the way you answer any of these questions when someone's asking you on the wards, your non-pharmacologic approaches and your pharmacologic approaches.
So non-pharmacological, we're going to think about maybe diapers.
Yeah, diapers
Is that
is an
something?
option.
And training, maybe. What about fluids? How much
Fluids?
fluid would you recommend
So
for these
in
patients?
a medical breakthrough, that's
Oh,
right.
whoa.
This is gonna
hold the
blow
presses.
your mind.
Concentrate, yeah.
Blow your britches. Blow a hole in your diaper. If you drink less fluid,
Yeah?
you will leak less urine.
What?
Bam.
No way.
Throw that across the table. Who knew?
That sounds like an exam question.
It totally is. It's like for the person having anaphylaxis to peanuts, the first thing you tell them to do, stop eating peanuts. So
Another interesting thing here, though, pelvic floor muscle therapy. So I would have recommended this to my patients after like a traumatic delivery. Maybe they had a pretty big repair, 3rd degree, 2nd degree even, but even for our male patients. So I've had a couple patients who've had like prostate surgery or PSA was high, worried about prostate cancer, prostate taken out, and they go for pelvic floor therapy.
Yeah.
And I've had it takes a while, 6 months, maybe a year, and then you start to see some real benefits.
I'd love to see the couch in the pelvic floor therapy room. A lot of incontinence accidents. Is there like a sheet?
A diaper everywhere.
Plastic sheet?
They
on
probably
the
have
couch?
one of those like floors where it's just like see-through, like walking through a grate in New York City or something.
The pelvic floor?
Just everything drops through, like a kind of like a mat. Don't pets? I don't have pets. Don't pets have like a what are they called? Litter boxes?
Clearly, neither of us have pets.
Yeah, I don't know. You could have that in your office.
I mean, we have 2 fish downstairs. But
Yeah,
there's no issues with urinary incontinence there.
You ever seen a fish diaper?
No.
No.
But that's a good idea. There's a business there. When it comes to other
You're finished. Scale up your.
Oh, wow. You were just on fire.
Come on, let's go.
Unlike the fish because they're underwater. Bladder retraining, another non-pharmacologic approach. It is a cognitive approach, and they use urgency suppression techniques.
Oh, that's interesting.
Very interesting. And in those with more advanced frailty, then what do? Alternative approaches.
And this is a nice way of, so this is a great euphemism, eh? For those in congregate living environments. Is that the new word for like a care home?
I guess so.
Or a
I mean,
nursing home?
we used to call it nursing home. Now we're not allowed to. Then it was care home, but
Care
I guess
home. So
we
congregate
stopped
living
caring,
environments.
maybe?
Measures. Prompted voiding, timed voiding, and containment may be appropriate.
Are
What
these
does
like
that mean?
activities they do? Like at 1 p.m. there's bingo. At 2 p.m. there's containment.
I don't know. Someone's gonna. I'm not the most intelligent family practitioner. Many people have told me. Someone's gonna have to tell me what containment in a congregate living environment. That sounds like prison.
No kidding. All right. Well, most of my patients are like, just give me the pill, doctor.
Okay, so what pill though? Because there's a number.
The number is 4.
4.
Glad you asked. So we got oxybutynin, solifenacin, we got fesoteridine, and mirabegron.
Mirabegron. I've used mirabegron and oxybutynin. Those
And your
are
patients
probably
are
my-
begging for mirabegron
Ooh,
because it's the most
nice.
expensive. It's got to be the best, right?
Is it? And urethral bulking agents. What is a urethral bulking agent?
I don't know, but I'm sure it can be beneficial for stress incontinence.
It could be
Older
in older
women
women
with
with frailty.
frailty.
That's
That's
reference number 10.
We'll
I'm going to
look
look
at
that
reference
up while you
number 10.
keep on going. That's an interesting one.
All right, so the problem with oxybutynin is that it's got a bunch of red flag issues. So folks typically tolerate the newer things. You're not listening to me at all.
I'm just intrigued. So reference number 10. Now they reference a 2000 study in urology. Injectable agents in the treatment of stress urinary incontinence in women. Where are we now? Well, we're in 2024 now. So referencing an
Nothing
article
new.
from 24 years ago with nothing more recent, I'm gonna say they put that in there for peer review, and no one picked that up.
I think so, yeah. So
Older women and
oxybutynin, let's get back to that
frailty.
one, shows adverse cognitive effects. I
Okay,
mean, some days I
sure.
wonder if you're on oxybutynin. The next one is solifenacin, which is lower risk of cognitive impairment.
5 milligrams a day dose, lower risk for that cognitive impairment, as you mentioned, and fesoteridine.
Fesoteridine, I believe?
Fesoteridine.
Yeah.
Do you prescribe that
We got,
often?
no.
No. I think that's going to be urology for me. Safe in vulnerable adults with frailty who may be living in a congregate living environment during containment.
All right.
I don't know. I hope I never end up in one of those places.
Yeah, it sounds...
Oh, and there's implementation. There's a continence product advisor. Now, Warning.
.org.
Continenceproductadvisor.org. Be careful if you're looking up this stuff at home. I have some really weird ads on my Facebook.
Oh dear.
When I have that
Those targeted ads.
targeted ads
You
after
got
a
like
day in the
15
clinic.
different diaper ads on
Yeah,
your screen there. Weird
And then
stuff
you just
coming up.
you think you're like, God, I need this. And then you go onto Amazon and they've got you.
You're like,
and
why-
then you're like Prime. You're like, there's a discount. I'm gonna save money. I'm a child of immigrants.
Why
I'm gonna
do
get
I
it
use
every
a toilet?
month.
Have you ever asked yourself that? You know,
I
some
spend all
people
this time potty training my kids.
could be relieving themselves during their podcast. And you'd never know. This last article, you know, I was under the impression that we were going to get no good medical research content from the avocado toast generation. And this article has proven that wrong. That's right. We're talking about avocados in IUD training.
Incredible. Now, you know what's the most incredible thing here is? Someone is getting avocados for $1.25.
That is the shocker there. That shows you the lag time between when you submit
Yeah,
an
yeah,
article and when it finally goes to print. Like all these
Avocado
folks-
inflation rates.
Yeah.
Estimated cost per student for simulation at see they got you there. As of time of submission.
Yeah.
They got you. That's
Exactly.
a good article.
Yeah, holy guacamole. That's a good article on avocados and IUDs.
I can't wait to talk about this one.
Taco.
Talk about this one. Hey.
So where could we possibly be going with this? I mean, avocados as a simulation tool for IUD insertion. So here's the story, is these folks were using the plastic models and putting the IUDs in the plastic model, and they said, pretty sure that when I do this in clinic, you don't hear it go click.
Yes.
They wanted something to go a bit more like mush or like
Yeah.
have
Or
a bit
something
of give to
something
it.
that would simulate endometrial tissue. And they found, and now they haven't referenced this, but the internal texture is consistent with endometrial tissue. So they haven't referenced that, but I'm going to assume with these 74
Okay.
people,
So
the
already
74
tearing this
residents
article
in there. I'm
apart.
just look. They use words like pedagogy and medical education. And you gotta be sure these avocados. And like, how ripe is the avocado? Did they use a ripeness scale?
Oh my gosh, you are just, this is not Journal Club.
I think
We're
it's
here-
yeah.
well, were they South American avocados or
Oh,
were they Arizona avocados?
interesting.
Yeah, exactly.
Did you just racialize avocados?
I see where the origin of where they come from.
Oh,
it's
interesting.
okay when you. Okay, I'm not going to double down on that, but I can tell you right now that they made a mess of these and then they taped them back together.
No. So what do you actually do? You cut it in half. You take the pit. Is the pit or the seed out?
Yeah,
What's the right word?
pit.
Mr. Avocado expert.
I went to the
Take
wrong
take
kind
the
of
pit
medical
out,
school to know.
and then you put it back together. Put some duct tape or on the outside or some medical tape. They even have the caveat. They were so detailed that the tape, the one roll of tape that they reference a price for, can be used by multiple medical students.
There you go.
You have to
Usable.
share. That's another
There
kindergarten
you
rule.
go. We got our climate emergency.
Oh, here they do
solved.
actually say moderately ripe avocado.
Okay, there you go.
So
they had a
detailed.
scale. Wow,
Amazing.
all of your objections are just being
It's
thrown.
just
under
torn
the
apart
bus.
if I actually read the article.
This is Nacho Day. I mean, yeah, it looks more like a Super Bowl party than an actual medical article with all this guacamole here. But
Interesting.
I mean, what's next? Let's be honest.
Yeah.
Where does this end? Like med students, first it's IUDs and avocados.
Yeah.
Next, it's going to be suturing quesadillas. Learning laparoscopy with churros. Like, where does it end?
It ends when you start to have to treat for obesity because everyone's going to eat afterwards. Like, this would be a great. This is.
It's a good fat.
It's a good. Is it? Is it?
It's okay.
I don't know. That's amazing.
So somebody said there was a comparable tactile sensation to a cervix and uterus when you put an
Okay.
IUD stick in a avocado insertion device. I don't know who that was or when that brainwave came. I'm sure there's a story involving a resident retreat somewhere.
Yeah.
I would love to hear it. Please comment below.
But yeah, but incredible. The great photography, great. I just think it's a skill. I mean, I just yesterday I had to even simply removing an IUD. You have to, it's a standard skill now. I think more people with the Nexplanon and that, but I think this is a great service. And if one more person places an IUD, and if one more avocado has to sacrifice itself for the sake of medical education, I think that's okay.
We're going to be hearing from the avocado lobby about the needless slaughter of
That was
avocados for medical
the
research.
most delicious slaughter I've ever seen.
Can't wait.
You salt it.
Wow. Well, I don't think we
Okay.
can top that. When it
I
comes
don't
to
think so.
dad joke medicine, that was probably the absolute best gift you could have given us A medical article about
Avocados.
Thank you, researchers, for what you've done for us.
Amazing. I can't wait to see what next fruit or vegetable shows up next month on Dad Joke Medicine. I'm Dr. Paul Dillon.
I'm Dr. Simon Moore. We'll see you then.
Recovery. No. I'll pull up my trump card. No.
Moving on. Welcome to Dad Joke Medicine, episode number 7.
I am so excited to be here. Dr. Paul Dillon.
Dr. Simon Moore. In this episode, we're going to cover the most clinically relevant articles from the September 2024 CFP Journal, such as
We're going to finish off by scratching the itch around eczema and treatments, steroids, and what else?
we're going to do a blazing article on heat stroke and complications, how to identify, manage that.
Getting hot in here just thinking about that article. And how are we going to finish off? This is one of our last podcasts for the year.
That's right.
What should we go back and review?
Back in time to last year's recommendations.
Yeah, 2023, Danielle O'Toole. We're going to go over some of a 3-part series. First one, we're going to go over that here. So should we dive in?
No, because we always start with the cover.
I've only done this 7 times, huh?
Okay, so let's
what do you
talk.
think?
This is our cover critique moment. Let's rate this cover on a scale of
I'm giving a -5. I'm sorry.
I didn't even give you the scale yet. On a scale of -2 to -4, you
That's
think
a
it's
great
amazing.
This is
-5 is an amazing rating.
It's like badly drawn puzzle pieces. I just think this is you and me, and we're just putting the podcast puzzle together.
Putting the puzzle together. A stock image for the journal. Yeah, it's lacking. I'd say that it leaves some empty spaces that need to be filled.
Yeah.
Why don't we dive into the clinically relevant articles here? So, flipping through to the first one, heat stroke. This is something that could absolutely show up at the CFP hospital for those of you writing the CCFP exam, but they really frame it in a case that could come to your family medicine clinic.
So what sort of a case are they going to give you? They're going to give you a case that's got lots of red flags. There's a great checklist in this article. Maybe I'll read a little bit. So your region is experiencing a heat wave. It's December, or it's late fall right now. Areas that could have a heat wave in Canada, British Columbia.
Yeah, southern British
Southern
Columbia.
British Columbia. Everywhere else is cold. I got pictures of snow in other parts of Canada. So for those places, what do you think?
Well, they could have a case just like this where a patient comes in for what seems like a routine office visit.
But maybe they have some comorbidities. Maybe they're a little bit confused.
Yeah, and then all of a sudden you notice their temperature is up, and you check their temperature, it's 40.3.
What? So what's normal body temperature? What's that range?
98.6.
Yeah. You're Fahrenheit off. It's actually 36 to 37.
All right, 36 to 37, completely normal, and she is just blazing hot. So this patient is at risk for heat-related illness and confused. They give a medication list. Is that even relevant? We're worried about her heat.
Let's come back to that when we talk about the risk factors. So what medications could increase your risk of a heat-related illness?
Okay. And in fact, what could this increase this patient's risk of heat-related illness? And I love this rapid risk assessment checklist.
So this is a great one because anytime we see a checklist, we're thinking about an easy SAMP question to write. So this one talks about an older adult, and they use that at 60 years of age or older.
Yeah,
they're pushing it. Either these numbers are going further down, or it's just my age is going up.
Yeah.
I'm getting closer and closer to this old age.
My kids think that I'm about 200 years old based on the looks they give me and the way they talk to me.
So you could have mental illness or cognitive impairment. That's number 2 on the checklist. Chronic disease, living alone or socially isolated. What else do they have, Simon?
Yeah, a few more risk factors. If this person is sedentary, if they're substance dependency or use, if they got impaired or decreased mobility, and then if they're taking medications. Once again,
Here it comes. So let's go back to what you were talking about earlier. So medications, and they split this up into 2. Medications affecting the cardiovascular system, and then medications affecting the nervous system. But you mentioned chronic disease as one of those things in that risk factor list, and you're going to treat these patients with a risk factor for heat-related illness, going to give them some medication, which will also increase their risk for heat-related illness.
You got it, yeah.
Are you a bad doctor or a bad person if you're doing this?
Yeah, exactly. So the folks who are being treated for heat-related illness and have risk factors for heat-related illness are probably going to be on medications like these. So beta blockers, calcium channel blockers. We mentioned another risk factor is that they've got mental illness, cognitive impairment, and those folks are going to be on what kinds of medicines?
Well, you're thinking about your antipsychotics, potentially lithium, anti-Parkinson agents. So a lot of these medications, you think of elderly patients living alone, polypharmacy, at risk. So what can we actually give these patients? What advice? And then I go to box 2 for this one.
You got it, yeah. So as a family doctor, I would say send them to Emerge. And now they're your problem as an ER doctor.
No. So where else can we send these patients? And this is where this topic gets really interesting. I don't know if they snuck this in on purpose, but they want you to send them to cool places.
So that's the way to prevent
Heat-related illness.
Send
Send them to cool places. So I was like, I'd probably go to the bar, have a nice cold drink, but that's not on there. That's not a cool place.
I think that my kids would say that the coolest place is any room that I'm in.
I've talked to your children, and they say the exact opposite, actually.
Okay, fine. Okay. So what kind of things would we recommend? You know, it talks actually about advocating in our community so that our community can have places with a maximum internal temperature, community centers, family or friends with air conditioning. That's all in here. What else could we suggest to reduce their heat-related illness risk?
Cool public places, churches.
Mm-hmm.
So I don't know if there's been like a randomized control study of the temperature in churches. I don't know if do mosques have higher temperatures or mandars or Sikh temples? I'm not sure why they specifically say churches. Maybe it's because they're made of stone.
Okay.
That could be it.
That could be
Maybe,
it, yeah.
Maybe I'm the one that doesn't know.
Yeah, I mean, I remember I was always told to go to church to avoid the heat. So there you go. Reducing risk of heat-related illness.
What sort of hot places would you go to from church?
From church?
Actually, I'd say if you avoided church.
This is not a religion episode. But I'm happy to share with you about that if you want to stay later after a recording.
Later. Okay.
Let me tell you about my friend. Not interested.
What?
Interesting.
No, tell me. What friend?
What friend? My friend with a cool home that I can go visit to reduce my risk of heat-related illness.
Oh, interesting. What's his name?
His name is light-colored clothing when outdoors or in the sun.
Okay, so I think we've burnt that topic to bits.
Yeah, okay.
Are we done?
I think we have exhausted that one.
Exhausted.
And,
It's gone up in smoke, really, I'd say at this point.
You were just firing on all cylinders with this one. Indeed. Love it.
I'm exhausted.
Exhausted?
Firing on all those cylinders. Exhaust.
Exhaust, because that's a hot
No,
item.
because that's what happens with combustion.
Combustion
In a car.
Engines.
Oh,
I wouldn't know. I would own an electric car.
Oh.
I don't yet. I can't afford one. I'm a family doctor.
That's for specialists.
Yeah, exactly.
Okay. Let's go. Rapid recommendations.
Done. Next article.
It was so fast I didn't even see. So, updates from guidelines 2023. This is part 1. Danielle O'Toole's got 3, so we don't know what's going to be in the final one. This one, I think she's stuck with like cardiovascular. That's the big stuff I took away from this. So, cardiovascular, diabetic, 2 pages, everything from 2023. What's your biggest takeaway here?
Oh my gosh. It would have to be the single most effective drug when it comes to not only cardiology and endocrinology, but also nephrology.
Water.
SGLT2 inhibitors. No, that's their arch nemesis.
Arch nemesis.
Yeah. We'll get to that with the wet phenotype of cardiovascular disease. But here it says specifically, you've got your patients with heart failure with preserved ejection fraction. We used to call this diastolic dysfunction. Now we call it preserved ejection fraction. And for so long, we're like, what do we even give them? There's no great treatments to help them. And now, bam, SGLT2 inhibitors.
So the key thing here is just to remember that heart failure with preserved ejection fraction. And then let's take that and go into heart failure phenotypes. And I'll tell you an honest story. Mm-hmm. So just 2 days ago, I had a patient and I thought he had like a touch of heart failure. He was waking up at like 2-3 in the morning, really short of breath, would go for a walk. Pretty like a med student history at 3 a.m. in the ER. And I came back to him. I said, you know what? I think you got like a little bit of like heart failure. And that's a heavy word. So I told him, and he was like totally down. He was cool.
Kids these days are not used to hearing the word failure.
Yeah.
I got to tell you. Like heart delayed success.
Heart delayed success. But this guy was not a millennial. So
Heart
I go back.
trying as good as it possibly can. Heart, everybody passes. That's what you've been diagnosed with.
Heart participation.
Heart
Your
participation
heart
ribbon.
is participating in your failure.
Thing.
So I go back and I start typing up my note, and all of a sudden I literally hear like weeping. Yeah, his wife, she was sitting there at the bedside, heard me say heart failure. And at that moment, she thought like her life was over. So it's just the value and importance of words. Then I had to go back and tell him after his echo, his ejection fraction is 65%. And she's like, oh my God, no. What happened to the other 35%?
Like, no, it's amazing. That's a normal ejection fraction.
Yeah.
Which is why you have heart failure with preserved ejection
fraction.
fraction. Yeah. So what about the folks with reduced ejection fraction, below 55%?
So then I think they say, what is it here?
Your angiotensin receptor neprilysin inhibitors.
Neprilysin. So that's new.
And then the
have you seen this yet?
Yeah, I had a patient today.
Okay. Oh, did you? Okay. I haven't seen it. It hasn't reached the Sunshine Coast yet.
No, right.
A little rural. That's your urban medicine.
This patient was so close to the tertiary center. They worked in the tertiary center, and they are taking the advanced drugs, and then they would also be on a mineralocorticoid receptor antagonist to enhance their diastolic dysfunction.
So you mentioned the different phenotypes. So this is a new de novo way of talking about our heart failure patients. Is it?
Good one.
Huh?
How did
is that
you
good?
de novo that?
Oh.
So it actually makes sense because when you have a patient with decompensated heart failure, they're going to fall into one of 5 camps, really. You can put them in these boxes. And what is the evidence for this?
Oh, this I'll have to check. Did they actually
say?
No
level of evidence provided. Well, this is like...
That's perfect.
But
That's fine.
This clinically. The cardiologists see this all the time. And I think we can all guess what is your first most common heart failure presentation?
Wet.
You got it.
Yeah. That was my patient. Bit of furosemide, Lasix, gone.
Yeah. I had a patient today who was so fluid overloaded that not only did they have the edema, but they actually had a blister on their leg that was filling with edema, like at the bedside where you could see it filling.
What?
Clear fluid. Their edema had ruptured. In fact, palliative patients sometimes can have it weeping out of their skin.
How long were you just sitting there watching this without doing any treatment?
Popcorn was made. We pulled up stools.
Watch and wait treatment.
Exactly. Yeah. So wet, easy, diuretics.
Okay. Second one, de novo, so new heart failure, as I mentioned. And then moving on for that, worsening. So someone who's chronic and they're getting worse.
They talk specifically about how to manage each one of these phenotypes, and we can bundle those together. Just use the guideline-based management and give them multiple medications to manage their heart failure.
Just keep going, especially for the frail and cardiorenal patients. Those are tricky. I'm often getting my specialist colleagues involved in those ones.
Yeah, and really they say, titrate carefully. You're going to be reducing the amount of drug increases you're making, adjusting and tweaking and titrating very, very carefully because you could upset the apple cart very easily. The
apple cart?
Mm-hmm.
I go to the supermarket. What an apple cart is upset?
Yeah, you've never heard of upsetting the apple cart?
No.
It's a manner of speaking when the apple cart gets angry.
Oh, okay.
Yeah.
It's some core truths there.
Mm-hmm. Yeah. I'm going to have to look for a sauce on that one.
Don't be saucy and tell me about one of these. So we just talked about medications we're going to give to patients. What about taking medication away? When would you do that in patients who have had an MI? Say it's one of your patients. You've horribly managed their heart failure. So most of your patients... Hypothetically, right? You have to say hypothetically, don't you now? Isn't that what the college told you, to always say hypothetically?
Yes.
So, patient with MI, you start them on the... Whoa! I got so excited there. You started them on a cocktail of medication.
I specifically remember, early med school, seeing this internist say to the patient, you've had a heart attack, you're going to be going home on 3 different medications.
And what were they?
We're talking about the statin, we're talking about the aspirin.
Yeah.
And we used to tell people beta blocker.
Yeah.
For life. You're going to be on this drug for the rest of your life. Wrong.
So now, at 1 year with preserved left ventricular function, consider taking these patients off.
What? We're going to stop a beta blocker in somebody who's had a heart attack?
So I've seen this a lot in my elderly patients, and they've just put on a beta blocker, set it, forget it, Ronco food dehydrator, easy family medicine, don't do it. But now, take them off at 1 year.
And again, it's one of these things that makes sense because we see these patients down the road, and how do they look?
Tired, depressed, and fatigued.
They look like a family medicine resident. They're so exhausted. Stop that beta blocker.
But they're tired because they're in their 3rd year of residency.
Yeah, exactly. 3rd year of beta blocker. So we need to be careful, though. We don't just stop at carte blanche. we stop it specifically for folks, like you mentioned, preserved ejection fraction. And then the ones who aren't having heart failure, they aren't having arrhythmias, and the ones who aren't having uncontrolled hypertension.
I've seen a few cases of this. After an MI, patients just get down, depressed, or they start on a beta blocker. I think it's undernoted. The depression and fatigue some patients feel on beta blockers. I've definitely had a few patients. I've stopped their beta blocker. They're active. They have an MI, and then all of a sudden they're just exhausted. Wow. Stop the beta blocker, they get better. So I wonder how many patients are going to get better with this recommendation.
Well, that is an amazing 2023 recommendation. There's a couple other ones. I think the most clinically relevant ones here are going to be, I love this one about if you've got a patient on insulin with type 2 diabetes, are they taking this medication as well?
Yeah, and so this is interesting. So start them on insulin, weight goes up, and they talk about adding a GLP-1 RA. So liraglutide would be one example, and that brings their weight down, which improves hemoglobin A1C.
Yeah, in fact, multiple trials have demonstrated that if we combine these two, so think about it, insulin plus GLP-1 RAs, and then you're going to get better body weight, you're going to get better hemoglobin A1C reduction than just using insulin alone.
And it's 2023. This was the 2020 Diabetes Canada guidelines. So this aligns with that. So another potential game changer, another benefit to your patients. Get that hemoglobin A1C down.
You know what the real game changer is, though? Is that this was the 2020 Canadian Diabetes Association guideline recommendation, and in 2023, the American guidelines finally caught up to the Canadian guidelines.
And then now we're printing them again.
Not the other way around. Usually it's the Canadians are following the Americans. So
Is that true?
When it comes to medical recommendations.
Oh, okay. Sure.
So you want to go into politics
Good
there?
recovery. No. I'll pull up my Trump card. No.
Moving on. Okay. So actually, I just heard a quote from somebody who said, he posted on his Twitter, I can't believe people want to vote for that old white guy. This is back when it was the two old white guys running. He's like, you wouldn't believe the amount of hate I got when I was just making a joke because they were both. He was like, I thought it was like totally nonpartisan.
And
but
it
no,
wasn't. I think everything is
polarizing.
partisan.
Look at you can see if you look at the number of likes on our video right now, you can see them going down because we brought up politics. Speaking of which, like, subscribe, and send us an email. Tell us.
Subscribe, share with your family members.
Yeah. And stop their beta blockers if they're over a year after their MI.
There, boom. Love it. Solid. Okay, let's keep going. Last one, the top article, Tools of Practice.
I love this article, the top article on this topic.
Ooh, this is topical?
Yes, that's
visible?
the first word of the headline. It's topical corticosteroids.
Topical corticosteroids for atopic. Ooh, another top in there.
Oh my goodness.
Ooh. Did they do that on purpose? Atopic dermatitis.
It's like a rap. Like these guideline authors are.
Oh, it's
rapping.
Michael Allen as well. What else does he do?
He's the CFPC CEO.
And he's publishing in the journal?
Not anymore. He's focusing on rescuing the CFPC. So why did we get canceled from the FMF?
Why don't they invite us on the CFP, the CFP podcast?
Yeah, I don't see your picture there.
Never got an invite.
No.
Staying human during residency training.
Oh, well. So let's talk about the risks and benefits of using topical corticosteroids for atopic dermatitis in children and adults.
So this article, what are my takeaways from this one? I really like the prevention piece of still using steroids 2 days out of the week to avoid flares.
Sorry, because we usually use, I've got to clarify this.
Yeah.
You've got a flare of eczema. It's really itchy. Use your steroid. Use it for a few weeks and then stop. Isn't that the usual?
But then, sure, you stopped, say, after like 6 weeks, but then use it twice a day. So weekend therapy is the way I would call it. So 2 days out of the week, use it to prevent future flares.
All right. And is there evidence for that? Well, actually, this whole article is about the evidence. So it talks specifically about that's going to help out 60% of patients avoid a flare. Compared to placebo, only 30% would avoid a flare. That's an impressive.
That's solid. And it's once again, it's patient-centered. Patients are going to remember maybe once, twice a week. That's going to be easier to do than every day. I know you forget, you're busy, but you know what? Once or twice a week, totally doable.
You know, I've got my doubts, though, because I wonder if the evidence might be a little bit thin when it comes to does that cause the skin to become thin?
Thin. So, do we have a lot of evidence on that? And I think the answer is no. I mean, I mention it to my patients.
Kidding? 35 RCTs? That's not enough evidence for you?
Yeah, but what's the N value? Yeah, 3,500.
576. So less than 1% of people will report skin
thinning.
Or thin skinning, I say, when I'm having dysarthria.
Okay. Oh, you're skating on thin ice right now, my friend. Tacrolimus, 0.1%.
Yeah, let's talk about the calcineurin inhibitors.
Because it's not just tacrolimus. There's a second one. Is there not in Canada?
Pimecromylase. I know you know how. I know you know what it's called. You just don't have to pronounce it. So, potency of that, is that going to be like a strong steroid? Is that going to be like a weak steroid?
I don't know how potent pimecromylase is.
Wow. Peter Piper picked a peck of pimecromylase. Potency. Wow. That's like the tongue twister you were using to try and warm up for our podcast presentation. So well done. So they would actually rate it as a mid-potency equivalency.
Okay. Sounds good. That's a great point.
Moving on.
Clinical. That's pretty mid.
Great for, eczema flares in the face. You don't want to be using your potent steroids. Because skin thinning can occur in 1% of folks. And turns out short-term adverse event is less than 6 weeks. So steroids are safe to use up to 6 weeks. Long-term harms?
Don't know. Too new.
And that is September 2024. CFP Journal. That is it for Dad Joke Medicine, episode 7.
I had a great time here with you. Hope you had a great time listening wherever you are.
See you next month. You want to know that bacteria so that you don't get Pseudomonas.
Oh!
Waiting for you to get it.
Yes! Here we are. I'm Dr. Paul Dillon, and you are?
Dr. Simon Moore. What are we going to talk about today?
Today we're going to start with the ears.
And then we're going to talk about some rapid recommendations, guideline updates on concussions.
And there's another part to this as well. It was
C.
concussions
Oh.
and COPD. See what I did there? Danielle O'Toole's part 2. We're going to go into that. Let's start at the beginning where we always do.
Cover critique.
Could it be better than last month's?
Oh, could it be worse than last month?
No, it couldn't be worse than last month's. So here we are. It's actually, it's a lovely spiral. It's like a conch cell.
You're spiraling already.
Too many C words.
We haven't even gotten into the meat of it, so I don't know which way we got to... It's like an optical
You just gotta
illusion.
spin it super fast.
And it's supposed to represent the... just like a spiral continues on, unbroken forever, so should patient care. Once you're a patient's family doctor, you're their family doctor forever.
It's not fractured care.
Fractal
It's fractal care.
Fractal care.
Fractal care. It keeps going and going and going.
Well, I think maybe you're right earlier when you said it looks the most like an ear canal.
Yeah, so maybe we should start there.
At the clinically relevant articles in CFP Journal this month, we got otitis externa.
And an approach to it. 6 authors. Something we
Wow.
see all the time. And this one even has a CASLPO as one of the authors.
It's amazing. So we got an audiologist helping out.
Yeah.
So we've got all sorts of details on what do you need to know about otitis externa. You need to know the bugs. You need to know the diagnosis. You need to know how to manage them pharmacologically and non. Where should we begin?
So I think we should start with the cerumen.
The serum.
So
the
this
wax.
is interesting. This I didn't know. This is new. I didn't know cerumen is mildly acidic and produces lysosomes that inhibit microbial growth.
So you've never tasted it?
No, I haven't. But I also now, my kids, when they're picking at their ears and looking at their earwax and spreading it on their hands or potentially in their mouths, I'm not as worried about it
Oh, fair enough.
because
Yeah.
it's cleaning.
It's got the
It's
lysosomes in
self-cleaning.
it.
It's like a self-cleaning oven.
I gotta say, like the amount of bodily fluids that I've ingested ever since children, cough in your mouth, drool in your mouth, sneeze in your mouth, like it's
They're
just unbelievable.
You know what? That's probably the one thing that kids have that inhibits microbacterial growth. Otherwise, kids are like petri dishes.
They're just like pus collection devices.
Yeah. As
So-
soon as one area of the child is like dry, there's another area that's oozing something.
Oh, absolutely, yeah.
God love
and
'em.
it could be their external ear,
Yeah.
and then we're worried about otitis externa. If they got that weeping eardrum, that weeping ear canal.
Yeah. Parents
So-
coming in with pain. And where have they been? I always ask them, like, have you been swimming? in fresh water? Have they been to the pool? Have they started doing swim lessons? So it's called swimmer's ear, colloquially.
So there's a few different kinds of otitis externa. They got the acute and then the chronic. And then sometimes you look in the ear and it looks like there's the white cotton candy.
So have you actually seen this?
Several times.
Ear fuzz?
Yes.
Not like dad ear fuzz where the ears get hairy on the outside,
the ear
but like
hair.
inner ear fuzz.
Yeah, have you seen it?
No.
Oh,
I
dude,
haven't
like
actually.
it is one of these things that the first time you see it, you're like, that's not, I wonder, it's a fungal ball.
Oh,
And they always
okay.
come back positive for aspergillus if you ever
Interesting.
swab them or send them.
Always.
Yeah.
That's a strong word to use.
Yeah, 100% of my N of single digits probably.
Single digits.
But
Amazing. Okay. And so other than that, if you're saying it's aspergillus,
Gillis, yeah. They, at the CCFP
what
hospital,
about the bugs?
Yeah, they love the bugs. They love to ask about the bugs. So usually it's going to be the big one we need to know about is going to be Pseudomonas.
Pseudomonas aeruginosa.
And you want to know that bacteria so that you don't get Pseudomonas.
Oh!
Waiting for you to get it.
Yes! Oh, that was great. Well done.
Now, the other one, you'll know if you have a large amount of people working for you. Should I say a large staff?
That's good.
A golden
A
staff?
golden staff.
Staff or really
Staff
stretching.
orient.
Come on, help me out, man.
Stretching. No, you're on your own
reaching.
with that. Okay, but that's great. So those are the two big bugs you need to know, and a fungus, perfect for studying for the exam.
Sometimes, though, you do the swabs, you do the tests, and they got the red, painful ear, and there's no bugs. We got to think about what are these other diagnoses that could be causing this. So you got your lupus.
Lupus, always lupus. You went straight to a house diagnosis.
Mm-hmm.
But what else? Seborrheic dermatitis, atopic dermatitis. So think about like what caused it. If you're doing a history and they haven't been swimming, they haven't been exposed to increased humidity environments, maybe there's something else. Maybe it's chronic Q-tip use.
Yeah, it could be acne, or as they like to call it, ear knee. I just made that up. That's not. Don't write that on your exams.
I was like, I have never heard of that
Ear
before.
knee?
God, Simon, you're so intelligent.
You haven't heard about back knee? All the teenagers complaining about back knee.
That actually, that's something we talk about at the review course.
Yeah, absolutely. So those are diagnoses that could predispose somebody to acute otitis externa. But I'll be honest,
go.
sometimes you look in that ear, it's actually really hard to tell the difference between that and seborrhea. So
Okay. But so what are we going to do now? Got this patient, we've made the diagnosis, painful ear. What are we going to do?
management, pharmacologic, non-pharmacologic.
Okay, so number one step is going to be get the drops in. So it's going to be topical therapy. In a certain number of cases, though, you've got to be thinking, what are the things that predispose this patient to perhaps getting into like malignant otitis?
Oh my
externa?
gosh, yeah, that stuff can be scary because that's got only one way to spread, and that's in. These are folks who could end up with, mastoiditis. They could end up with an osteomyelitis. They can end up with brain infections if we miss that.
Brain infections.
Brain infections.
Brain infections. That's just a catch-all term. You have a brain infection.
Yeah, so that's why they call it malignant. Usually that's going to be the older folks, immunocompromised.
It's diabetics. I've had some patients. So I almost consider it like a diabetic ear and like a diabetic foot.
Yeah.
So that's the way you got to think. It's this end stage, end of your body. It's not an end organ. But you got to think like, okay, could this get worse? So then you're considering antibiotic oral therapy. Now, the article does point out a lot of times we do overprescribe potentially in this area. I don't know if you've heard about that.
I have not heard about that. No,
You didn't even get my joke.
not heard about that. It was too
Obvious.
too obvious for me. You just keep banging your own drum there with your amazing jokes, if you must.
You're waxing poetically about me, aren't you?
Waxing. Come on, let's move down the canal and get to the meat of the matter.
Yeah.
So management for these folks, the topical therapy is going to be first line. And how do you even get the drops in? There's great recommendations there for making sure those drops get instilled properly.
So I think often when you see a prescription, it'll say like 2 drops or 4 drops and trying to count the little drops in that tiny little container. So the article actually gives some great advice. It says get your patient to lie on the side, fill the canal, which is much easier for a patient to understand. You could play around with the tragus, pull the ear, have someone else do it, and then sit there for 5 minutes. So 5 minutes, pull the ear, get the antibiotics in there, plus minus steroids, depending on what your local practice patterns are or what your pharmacy has available.
Yeah. Sometimes, though, I know people get really worried about, the kid's got a tube in their ear or they've got maybe a tympanic membrane rupture. Can we still give a fluoroquinolone eardrop? Totally fine. They're not ototoxic like some of the older antibiotics that we used to use for this. So the quinolone drops are totally safe.
And what about an oral toilet or a wick?
Oral toilet, spelled A-U.
A-U.
R, like
Yeah.
auditory
Yeah,
toilet.
yeah.
A wick. Why don't I wick
Do
you
you
would
do
tell
this
me more
often?
about that.
Huh?
I wick you tell me more about that. No.
That's the best worst dad joke.
The best worst dad.
Is there a
joke.
really
Groaner?
bad dad joke? It's a groaner. I don't know. I don't want to listen to you anymore.
Oh.
I wish I had bilateral otitis externa listening to
Send
some of
you-
your jokes. So what do you do? So they talk about cellulose fibers. I've never seen that. Just using like a cotton wick, get the patients to lay down, put that in, and then immediately, once you get it in, and I feel like this would be quite painful. I think I'd almost use a bit of lidocaine or something first, potentially. And that doesn't show up in there. And then put it in, add the antibiotics to the tip of the wick, and it should fill up, draw the antibiotics down, and then bring them back and reassess them.
Yeah, get them back in 24 to 48 hours. See if you can see that eardrum at that time. If not, you're going to, what does it say? Repeat the wick. Definitely not something I've seen a lot in primary care. It says if you can't see the TM, remove the wick and then continue the drops for a week.
It's like a little birthday candle. What about
Yeah.
ear candling?
Ear candling?
I've never done that.
No. It's
Do
a
you
great
know
way to
anything of
burn
it?
people. Yeah.
Oof.
Causes burns,
Okay.
not safe, not effective. You mentioned cotton. Are you actually advocating for cotton swabs?
Never.
That's right, yeah. The ENT docs I work with say don't put it in your ear if it's smaller than your elbow.
So I'd love to actually see what people do. That's one of those tips people give you.
The Q-tips.
Q-tips.
Yeah, exactly. Now, the thing is, otitis externa, great. You give the antibiotics, should work fine. But what if 6 weeks goes by, 12 weeks goes by, 3 months down the road, they're still having symptoms? What's the diagnosis now?
Now we're getting into chronic otitis externa. So you got to think about, could there be something else funny going on? And then you're going to think about, acetinoid oil drips for itching.
Yeah, those fluocinolone.
Fluocinolone. Have you ever prescribed that?
Yeah, we give the ear
do you?
steroids all the time. The ear
Okay.
lotions. I've seen clobetasol used as well.
At that point, I'm thinking about referring to ENT.
Great.
Yeah.
So I think that's going to wrap it up. That's the...
Had an earful, really. Is there
nice.
more?
I think we should
there
exit the externa article. And move on to some rapid recommendations. So these are some guideline updates that have been compiled by one of our colleagues and things that we should know. This is part 2 of 3.
Yeah, so one more coming up this year. Exciting. So we talked in our last episode about cardiovascular, about some diabetic updates. But so this really falls into the two C's. So COPD, a couple of updates. We talked about this in the course, I think, fairly extensively. And then some new Ontario's living concussion guidelines. So I don't know if Ontario guidelines are applicable to British Columbia.
Yeah, it's too far east.
Yeah. And like the weather,
The
and
time
the people,
difference,
the physicians.
I'm from Ontario.
Oh, yeah. Like I
Easy.
said.
Yeah, there's the line. Yeah, exactly. So they've got a living concussion guideline there and some great recommendations with zero evidence provided.
Perfect. That's how I like to practice.
Yeah, like, how is that even in the guideline? Well, consensus guideline, they're saying, look, get active. That whole stepwise return, like laying in bed until your symptoms are gone. People are laying in bed for weeks. No, they say within a day or two, 24 to 48 hours, gradually increase intensity of your activity is tolerated as long as you're not prolonging your symptom exacerbation.
Yeah. So get active. You can take a short break. 48 hours, you need to be getting back and doing some physical activity, getting back. Yeah. I think that's across Canada. We can take that from Ontario. Actually, I think it's in the Canadian guidelines already.
Now, what if those folks 3 months later are having cognitive fatigue?
I love this one. I have not heard this before. Had you heard about this before?
Not for
the
this
article?
indication, but hey, it's in the guidelines
Yeah.
and level A evidence.
Wow. Methylphenidate.
I like how it seems like the author doesn't even agree, and it says healthcare providers are encouraged to appraise the recommendations further before incorporating them. Maybe they're referring to this one.
So I don't know. Like I can think of a very specific patient where this may actually work, where it would almost give hope potentially, but it might work. I don't know. I haven't tried it. It wasn't, part of my armamentarium of like post-concussive symptoms to throw in methylphenidate, but
That's right. Yeah, they're recommending methylphenidate as a treatment.
yeah, 5 milligrams once a day.
Maybe even twice a day, and to give you better alertness, better processing speed, better attention, and better working memory. So
Give it
that's
a
in the
shot.
guidelines.
It may help a patient or two. You never know.
Yeah, and then definitely talk to your provider before discontinuing use. And then the third recommendation about concussions
Blue light therapy.
Blue light therapy. Go to a rave. When you've got that, that nausea,
That pounding
dizziness.
concussion.
Yeah,
Boop, boop, boop.
there you go. So go to a blue light therapy, and they're talking specifically. I think that it's really important to know the nanometers of wavelength. Wouldn't you agree? Don't you think that
Oh,
could be a good
absolutely.
exam
Yeah,
question?
460 to 480 nanometers.
None of that 485 crap.
Too much.
Too
You'd
high.
overdose on blue light. You see that
Unbelievable.
Vegas show, those guys.
Yeah.
Blue Man Group, they
Blue
all
Man Group?
overdosed on blue light therapy.
Unbelievable.
Let's just change it. They turn
like
into
the people who-
Smurfs.
It's like the people who eat
Le-
too many carrots. They turn orange.
Yeah.
These guys were just depressed.
Les Strumpf.
Cranked up their blue light.
French.
Yeah.
Did you know that?
Apparently, what does blue light do? It suppresses melatonin and increases alertness. So, sleepiness, fatigue, depression gone if there's blue light. So just watch DJM videos over and over again. Let's crank that blue light behind us to 480 nanometers.
There you are. That's a number to remember.
COPD. Everyone gets what? Do they get? They get a short-acting beta agonist?
And what?
No, that's
No,
old.
old.
That's old news. What is the new recommendation?
Long acting. Lama or laba. Sounds like a sheep is saying all
like a
these
lamb.
things. Lama.
Lamb.
There, that's a great way to remember it.
Really
Don't be
too much-
sheepish. Don't be sheepish.
too much-
Get your patients on long-acting medications. Don't let them pull the wool over your eyes.
Wow. Just honorable here. All right. The Sheep Farmers Guild has clearly been influencing these guidelines. I'd like to see the conflicts.
Yeah.
So they say, LABA or LAMA for all patients with COPD. In fact, some of these folks who've got a high COPD assessment score, they're saying they should even be getting dual LAMA-LABA right off the bat.
Whoa. Wow.
No,
Okay.
Well, if you think that's a lot, wait till you hear the next recommendation.
Hold on. More drugs.
Yeah.
Yeah.
Triple therapy.
Triple
Specifically triple therapy. So they talk who should be getting triple therapy in COPD, those who are high risk of exacerbation. So those are your LAMA-LABA plus steroids.
And this actually is the strong recommendation with high quality evidence.
It's interesting, though, because they don't talk specifically about the higher risk of that. And I know there's some good tools for practice about the increased risk of pneumonia if you're just dumping steroids into those lungs nonstop.
chronically?
It is
Sure.
measured. But they specifically talk about how, if the blood eosinophil count is high,
Right.
yeah,
Then you
0.3
consider. Yep.
10 to 9 or higher, then those folks are going to do really much better conditionally. The recommendation is conditional. It's an amazing recommendation conditionally. If they got high eosinophils, to give them steroids as well.
Okay, there you go. That's a great little practice tip. So that's part 2 of Danielle O'Toole's. So we did COPD, we did concussions, get these patients back active, maybe methylphenidate.
Great
Maybe.
summary, Dr. Dillon. This has been Dad Joke Medicine, episode 8.
8. We got one more coming up, I think, this year.
Episode 8, I got to say, making me hungry.
Why?
Are you hungry or no? Because you already ate.
8. Oh.
Wrap it up with a dad joke.
On
DJM,
that.
we'll see you next month, where the jokes, I promise, will be much worse.
Dr. Paul Dillon, see you next month.
Dr. Simon Moore, take care. They will not replace your hardwood, as they are a pelvic floor physiotherapist, not a household floor therapist.
No.
Welcome to Dad Joke Medicine. This is episode 9.
I'm Dr. Paul Dillon. So excited. Last episode of the year.
I'm Dr. Simon Moore, and we are going to cover today, hot off the press. This is the CFP Journal November-December joint combined issue,
That looks amazing. It is literally hot off your press.
jam-packed with
Printed.
incredible
And-
tips and tricks.
Let's start at the beginning.
You got it. What are we going to cover today?
What are we going to cover? Exactly. We're going to do 3 articles. We're going to start off with GSM, then RSV, and then,
LACs.
yeah, boom. There we are.
You got it. Okay. So let's start with a cover critique here. And this is intended to talk about patients attending appointments from the comfort of their own homes with virtual care.
And what it looks like is it's a physician that's sitting on the same couch who's brought a giant frame and just put it in front of them.
Yeah, exactly. I'm going to come to your home, do a
telemedicine.
home visit,
Home visit.
but sit behind the plexiglass.
Yeah. Oh, that's probably what it is. All those shares in plexiglass from COVID. I lost all my money.
All right, so let's start about
Okay.
GSM. And hold on, isn't this supposed to be Vaginal atrophy?
No, so this has
Atrophic
changed.
Vaginitis?
I've seen this in a number of articles over probably the last year or two, almost 3 years.
Yeah,
So
SOGC guidelines have got
GSM,
new name for this as of 2020.
genitourinary syndrome of menopause. So
Really
this
good-
includes, what is it? It's not just vaginal atrophy.
Mhm.
Both vulvovaginal and lower urinary tract symptoms resulting from decreased estrogen levels during menopause. GSM, so much easier to say.
Oh, absolutely. And it also leads into some of the causes and also the effects of this, and folks getting increased urinary tract infections. So I love how it broadens your idea of what this is.
And significantly undertreated. So I
Oh,
think
yeah.
they say 77%.
Mhm.
Yeah. Genitourinary syndrome of menopause. 77% of women. Often not talked about, underdiagnosed, undertreated. So let's dive into this.
Yeah.
Great article.
Yeah, we got to be screening our patients. It says specifically to be asking our patients age 45 to 69, during routine workflows, during your pap test appointments, ask them about it.
Yeah. And if you don't ask, you're not going to know. So what are we going to do? So say we have a patient who's come in. We think this is what's going on. So what are you going to do? What's your first line?
So first, make your diagnosis and then ask about management with non-pharmacologic treatments, your hygiene, your lubricants, as well as your moisturizers, and very, very different treatments for both of those.
So the first thing that I want to remind people about is you got to moisturize for a month. You think about Menses, it's for a month. Sometimes people will try one of these treatments, and there's different ones over the counter, so often not covered. So you've got to think about that when you're counseling your patients, but you got to try it for a month.
Yeah, it comes in gel, it comes in ovules, comes in ointments as well. But yeah, tell them to use it 2 to 3 times a week. And if they come back at 2 or 3 weeks and they say it hasn't worked yet,
Make sure you do that whole month.
moisturize for a month.
And now, next step after that, you want to go on to vaginal estrogen therapy. So this, you go more than a month, you go to your, I guess I would say, a steroid season.
Use your steroids for a season. To know
So
that
it's got to
they're
be,
actually working.
3 to 4 months is how long it's going to take for these to really kick in.
So I love this article because as somebody who has never suffered from GSM and maybe haven't learned a lot about this in my training, not only does it give the usual list of here are all the options, your rings, your creams, your pills, your soft gels, but it also talks specifically about why you might choose one over the other. It's got the prices in there. This is such a well done article.
Yeah, great article, great table there, especially if you're not that familiar. Maybe you don't have a lot of patients that you've been asking about, but now, trust me, you're going to ask one patient, you're going to ask another, and you're going to start treating, and great benefits.
You got it. So you don't even need great benefits to afford some of these medications. So these estrogen creams, the conjugated equine estrogen, comes from horse
Do you smell that?
urine. I smell the cost effectiveness. It's $10.
But what about the smell?
That's
So
right.
the
It's scented.
Equine ones
Yes.
are scented rose. Tried to do a
Rose.
deep dive and figure out why rose was picked. Don't know.
Doesn't really say. So rose scented, but obviously any scented products could be irritating.
Potentially.
So if that is, they come back, they say, don't love it. So then you can just move on to the estrone vaginal cream, which is unscented.
unscented.
Some folks don't want to be applying things most of these need a loading dose. Everything except the ring needs a loading dose. And some people say, look, I don't want to be using a cream daily for 2 weeks and then reduce that. So they say, what could I use once every 90 days?
What is that now?
Well, if you ever are not sure, you could just give me a ring.
Oh, nice. That was good.
It's an old phone reference, like a 90s joke about telephones. 'Cause
There's people who are
ring.
listening to this podcast that have no idea what you're talking about now.
Why do telephones ring? Yeah, I took my kids to a museum. I showed them one of those old phones
Yeah.
that doesn't have buttons. No idea how to use it. No idea. So what about the ring? $30 a month.
Okay.
Pretty convenient. And once every 90 days. And then if that's not something they want to use, the tablets and the soft gels. And once again, the article talks about the difference between those as well. You know, the tablets are going to use an applicator device. Comes in with a single-use applicator, but the soft gels don't have an applicator device.
So when we're talking about these vaginal estrogens, there have been concerns in the past. A black box warning, Health Canada, breast cancer. So these black box warnings are still there, even though SOGC has in clinical practice are using it. But the black box warning advised communities of risks including coronary artery disease, stroke, venous thromboembolism, breast cancer, endometrial cancer, and all very real concerns. So a great practice tip is to warn your patients that this is an old black box warning and it's safe.
Yeah, and that's the bottom line. It's safe. There's overwhelming safety data, even though the black box warning is still there. Another really good one you mentioned too is about breast cancer. If I've had breast cancer, can I use a topical vaginal estrogen?
So the short answer, yes. So you'll see it.
It says not to in the monograph.
It's often used off-label. It's used across the country. I've seen it as well.
Amazing. Now, what about GSM using those newer medications? You know, the ospemifene and the prasterone, not adequately studied in folks with breast cancer.
Sure,
So,
but for other people, another option. So a tablet if they're really not into using the creams, another option. So those are the SERMs, selective estrogen receptor modulators.
Now, we spent a long time talking about drugs and creams. What are the non-pharmacologic options? Hygiene. Avoid those irritants, those rose-scented creams that you prescribed.
Avoiding toilet paper made of recycled paper. That's an interesting one.
Great for the environment.
Climate friendly.
Bad for your vulva.
Yeah.
And regular sexual touch can help by increasing vaginal blood flow and secretions.
Okay.
Definitely not a dad joke medicine episode I'm going to
No.
play for my kids.
No. Yeah. Not safe for kids.
Yeah. Whether with a partner alone or with or without a device.
Okay. There you go. Boom. Physical changes associated. You can have narrowing. You can use vaginal dilators as well. And dyspareunia from dryness can also be an issue.
What is an allied health referral that is absolutely in your armamentarium for folks with, post-delivery vaginal symptoms, vaginal dryness, genital urinary syndrome, and menopause?
The answer to this one.
Well, since nobody
Pelvic.
here seems to know,
Come on, ask me. Pelvic floor physiotherapy.
you got it. Just be sure you remind your patients that they are quite invasive in their exams and their assessments. It's not like I can do some arm stretches. Not that kind of physiotherapist. And they will not replace your hardwood because they are a pelvic floor physiotherapist, not a household floor therapist.
No. Oh my God.
If it hurts your head, that means it was a great dad joke.
That's brutal.
I saw the pain there.
Okay, and the one thing we haven't mentioned that's in here is UTIs.
Oh yeah.
So reduction in UTIs. If you've got a patient who's had 2 UTIs in 6 months, 3 in a year, you've got to be asking these questions. Maybe you can avoid UTIs. Yeah.
Phenomenal. Let's move on to something that is relevant to our newborns. And in fact, even before they're born, our pregnant patients might want to take these medicines to try and prevent RSV.
RSV. So this was new to me. I've heard this. There's been some advertising. I've seen the new Health Canada updates on this, but essentially 3 things. 2 monoclonal antibodies, the injections, and these are for kids, little kids. But which little kids? Is it every little kid? Is it every province? What are some kids you're more concerned about where you'd be thinking about the monoclonal antibody?
Well, it depends who you ask.
Okay.
Because if you ask Health Canada, they actually say we should be giving a monoclonal antibody to pretty much every kid who's newborn about to enter their first RSV season. So why don't we do that? Why don't we give it to every single newborn?
Probably how much it costs.
Yeah.
And it's up to the provinces, essentially, to implement. I know Quebec, Ontario, 2024, 2025, it'd probably be 25, 26, where they're implementing programs. So it's not everywhere, but be prepared to answer questions from your pregnant patients about this. And so that's the monoclonal antibodies. That's for the kids.
That's your pavlizumab and your other one. What's the other one?
Nivirizumab, is that
It's
right?
got RSV in the name.
In the name. There you go. That's a great way to remember it.
Yeah. Nivirizumab is the one that is recommended by Health Canada for every kid, but it's going to be pricey. It's going to be $952 a dose.
And we should probably talk a little bit about those kids. So immunocompromised, pre-existing cardiorespiratory disease, they're premature, and residents in indigenous, remote, or northern communities. So that's a great list. Could show up on an exam.
Now, what if you're lazy and you don't want to just give the monoclonal antibodies? You say, I want the pregnant parent, I want the pregnant mom or the pregnant person to make the antibodies for me.
Put them to work.
You got it. Give it, and it's actually a third of the price.
Oh, interesting.
Yeah. So instead of getting a lab to make the monoclonal antibodies, why do you get the
mom to do it? Maternal labor.
Get them into labor before they go into labor. And
I hope that vaccine doesn't do that.
Yeah, exactly.
So 32 to 36 weeks.
Yeah, you're going to give them a dose of a vaccine called Abrivso. Abrivso, and not to be confused with Arexvy. Arexvy, that's the vaccine you've heard of in the ads that is really useful for folks 60 and older.
And there's been cases where they've mixed these up. I think there's actually a
really?
warning.
I
Yeah,
didn't hear
yeah,
about
yeah.
Okay.
They've given the pregnant patients the over 61.
So the Abrivso is the one that you want to give to the pregnant folks. It's the pre-F version of the RSV, and that only is going to cost you about $230 because they're making the antibodies for you.
I feel just looking at all these names, have we reached peak difficulty in medical pharmacological treatments?
We're running out of
We're
consonants.
running out of consonants.
I got to say, though, the monoclonal antibodies have been amazing for my Scrabble game. I think that nirsevimab is like an 8,000 point word.
You just make it up if you're playing with non-medical people.
You just like dump the box.
As long as you get like an MAB, you're done. You're going to win.
MAB.
The second, it's there's 3 letters. Boom.
So it does help. It does reduce the amount of ICU admissions. It does reduce the amount of RSV infections. Very interestingly, the old version, the pavlizumab, you have to give it once a month for 4 months, $1,200 a dose.
Wow.
The new one is the longer acting one. So that's the nirsevimab, and it works for up to, 8 months. They've got data for 150 days, and they expect 8 months.
Okay.
And the vaccine, of course, you give it to the parent before they give birth, and then they get 6 months of antibody protection for the kids.
So you're essentially buying time for these kids at higher risk for complications if they get RSV, and hopefully they get past 2 years. And then I think that's where the indication essentially stops, because you've gone through 2 RSV seasons, you've hopefully grown up, and you're able to handle it when you do get it.
Yeah, I mean, if you've seen RSV in a newborn, it's just clinical support like fluids and oxygen. It's really tough to do much more than that. And finally, we can now say, yeah, you could have prevented this. Really useless thing to say.
Now, they don't actually go into it. If you have a second pregnancy, do you get it again?
RSV again?
Do you get the vaccine again?
With
give
each
it to the
pregnancy,
mom
yeah.
with
Wanna
each
make the
pregnancy? It
antibodies.
is? Okay.
I believe so. So we'll look that up.
Okay.
Thanks
Just
for your
threw
good
that
question.
out there.
I'll ask
higher
you a
levels.
tough question for
Yeah.
the next one. I bet you don't know anything about simple excision and wounds, do you, as an ER physician?
All the time. I love these. It breaks up the day. You can save some time if you're using glue, but this is actually a pretty decent article.
Yeah,
If you
I would
look
say
at-
that they really sliced into the evidence nicely
they
on this.
just cut it down. It's a cut above this article.
It's a sticky topic.
Oof.
Glue for incisions. So what do we use? Do we use the steri strips? Do we use the glue? Do we use the sutures?
Or a combination, all of the above.
What does the evidence say?
So I think context is important. Simple lacerations, clean with tap water, and repair with clean, non-sterile gloves. So this is something I've seen in the past 10 years. Used to use all that sterile water, very expensive water, and now it's normal tap water within Canada. Spray, 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 wash, wash, wash. Copious irrigation, and just use normal gloves. You don't have to use sterile gloves.
Oh yeah, I've seen patients using peroxide, chlorhexidine
Oh,
on
yeah.
these wounds, and one of my favorite tricks for lacerations, you numb up the area, and then once it's numb, you say just put your arm under running water,
Oh, yeah.
clean out that wound, wash out all that bacteria while I go do some charting. See
Yeah.
another patient.
Oh, interesting.
Nice clean wound. Learned that from an EM podcast about 15 years ago. So,
Wow.
so what does the evidence say? Which one's going to dehiss? I mean, it makes sense. If you stitch something shut, it's going to stick together a lot better than if you glue it shut. But we actually now have the rate.
Yeah, but it's not a huge number. What do they say here, Simon?
It's 4.5% with glue
versus
are going to dehiss.
1.3. Yeah, so like 3%, 17 RCTs with an N of 1,200. So they're pretty small RCTs.
Differences with infection doesn't matter. Same
Yeah,
amounts of
that's fair.
infection with glue, with steri strips, with tape. They compared skin glue versus tape, and then they specifically compared suturing with skin glue. No difference in infections in those studies. And do you even need to close a punch biopsy?
So this is interesting. So 4 and 8 millimeters. My big takeaway from here is cosmesis, patient satisfaction. At the end of the day, it's almost all the same.
Yeah, a 4 millimeter punch biopsy, they say, small study, 77 folks with RCT. But if you just do your punch biopsy and say, see you later, here's a Band-Aid, it's going to be just fine. It's
No
gonna
difference.
Close.
Yeah.
9 months later, no difference in clinician-rated cosmesis.
Yeah. But now the caveat there, half the patients did prefer to have it closed.
Makes sense. You don't really want to leave your doctor's office with a gaping
Holes
wound.
all over. 4 millimeter holes all over you.
It's the Swiss cheese model of patient safety. Well, have we reached closure on this topic on skin closure?
Oh, nice. Yeah.
I think we've reached closure on Dad Joke Medicine for
Dad Joke
2024.
Medicine. What a great year.
Wrapped up CFP Distilled for 2024. That is the CFP Journal topics, all distilled down for you. Really useful, I hope. Signing off.
Signing off. Hope
For
you
the
have
year.
a great holiday season, and we'll see you next year.
You got it. I'm Dr. Simon Moore.
Dr. Paul Dillon.
Till next time.